inform the patient, inform yourself.
Thank you. So if you did the endoscopy early, you can see the likelihood of mortality is high. So don't want to do it quite early. Why do you think they had mortality early? If you scope them early, Karthik, you're Mr. Master of Ceremony. Why do you think they died early? If you scope them too early, why do you think they died early? High risk. Absolutely. I can go back home now. It's all ABC. It's simple, isn't it? So if you scope them too early, you're not resuscitating them. You're rushing and scoping them early. They often have pneumonia, and they die from pneumonia because there's a huge pool of blood in the stomach and esophagus. You stuck a scope down, and they get aspiration and they die. And of course, if you leave it a little bit late, and they also die, but not as much as early. So the optimum time is around 12 to 24 hours. The same holds for the stable patients. Doing them early again, it has similar poor outcomes. So the magic time is around 24 hours. So this is usually a good news for most endoscopists. Then you can say that get the ABC right first. So we're going to have a patient. This is patient of Dr. Basamani, who's given consent for, he does a lot of private practice in America. For those who don't know, this is Mark Zuckerberg from Facebook. He owns Facebook, which is now called Meta, I believe. And this is Basu. So he's been asked to see this patient. The patient is unstable, and he wants to know when is the right time for the procedure. For this, as you can see, how do you know an unstable patient? I would say an unstable patient is someone who has a high blood sugar score. If you look at the blood sugar score that I showed you on one of the first slides, it means that they are really, really ill. So you can either think about urgent endoscopy, 6 hours, as we've already talked about, or think about endoscopy within 24 hours. You want to know if we do it. So in this study, they have the mean time for the urgent endoscopy was done within 10 hours or 25 hours. So if you can look at this sort of they compared the outcomes. And again, if we look at the mean time to scope, looking at the intervention, i.e. which patients needed intervention, as in clips, injections, and over the scope clips, you can see that the ones who actually were scoped early needed more intervention. So being early, you're not actually doing any favors. You're trying to do more work for yourself and for the patient. So it's probably not cost effective. And your patients who have an early endoscopy also tend to rebleed early. And they also have a high likelihood of dying. So perhaps you've got to think about resuscitating first. What about blood thinners? A lot of our patients currently take simplest from aspirin, clopidogrel, warfarin. So for this, what's your decision based on this? Your decision will be based on, if it is aspirin, the only question you need to ask yourself and the patient is the patient taking it for primary prophylaxis or secondary prophylaxis, i.e. if they've had an illness before, then it becomes a secondary prophylaxis. Then if it is secondary prophylaxis, you would want to continue, because the evidence suggests that if they are taking for a secondary prophylaxis, you do not have a risk of cardiac disease, cardiac infarction at the time of bleed. Whereas if the patient is on warfarin or DOAC or clopidogrel, you would want to interrupt these medications. Again, I alluded to this, get it right first time, because getting it right first time reduces the need for repeat endoscopy, reduces the need for interventional radiologists. Are there any interventional radiologists in the room? We're very grateful. They're working hard this morning. That's why they're not here. Thank you very much for all the help that we love you guys, and thank you for the help. So the early that you intervene and getting it right first time, which is basically meaning ABC, you require less repeat endoscopy. We can keep our interventionals guys happy. Thank you to the surgeons as well. Keep the surgeons' need for surgery also is reduction. So, and this is very important where we're standing. Cash is king, By the way, for the foreign delegates, foreign faculty, the Kash word is Tamil. It means Kase. Kash is king, but Kase is also Raja. So the word Kash comes from India. So the payment is expensive if you don't get it right first time. So do we need to, now we're coming to endoscopy. So what do we do when you see, we put the scope down and you can see various features. It's useful to classify them based on the forest classification, because if you have the forest classification, you can predict the risk of rebleeding. So you got to know which ones you're going to intervene. I know my colleague, Dr. Mohammed Noor, is going to talk about interventions, but briefly saying, you need to only intervene in these sort of lesions, because these are the ones which have a high risk of rebleeding, up to 30%. These have a lower risk of rebleeding, so you do not need to intervene. So there are various kit that you can use, from injections, clips, and gels, and various other stuff that we can use. We'll cover this later, but certainly doing something at endoscopy, either an injection or a clip, has benefits. As you can see, the risk of mortality and risk of rebleeding particularly is reduced if you're intervening with dual therapy. So consider doing dual therapy, i.e. inject and use a clip or other heat for your treatment. So what about sprays and gels? There are a lot of sprays and gels that we use, and they are often useful. As you can see, that's Hemospray, and this is Purostat, which we'll be using. I know it will hopefully India, we should be introducing Purostat quite soon, but we're introducing that in our course on Monday and Tuesday. So they are helpful, particularly if the access is difficult, or if it's a failed therapy, or you want to do a bridge before you send the patient for interventional therapy, such as radiological. So I know I'm going to briefly mention about over-the-scope clips. That is my fellow who's inserting the over-the-scope clip. And these are quite helpful as first line, particularly if the ulcer is too big, or if there's a large visible vessel, or if there's a sort of fibrous ulcer, or if they're in high-risk areas, you could consider this as first line. Always consider rebleeding consideration. Think about how do we define rebleeding, think about the Rockwell score, think about the patient factors, and think about rescope or surgery. Have a rebleed plan, which should include your sort of rescue and see what you can do. This could be stents, this could be Sengstaken, or your tips. So Danny stents are quite useful. I know Dr. Mohammed is probably going to cover a bit. I'll just briefly mention it's certainly better than balloon tamponade, because you don't need to put the patient under a GA. The patient can continue eating as well. Once they have a Danny stent, the feeding can continue, or you can use, because if you had a balloon tamponade, that's going to come in way of feeding. What about where, this is my colleague, Rina Sidhu. This is a study which was done in our own unit, where we compared the outcomes of having a protocol-based service, which is very robust, which is what Apollo and KRP, Professor KRP's team is aspiring to. So having a very dedicated protocol-based unit for GI bleed. As you can see, if you have a very dedicated protocolized group, your likelihood of rebleeding and need for surgery is very low, suggesting look after these patients in a dedicated area. I'll briefly mention about training. So we know that training adequately for your trainees helps to improve their theoretical knowledge, improves their hands-on skills, and improves their verbal commands. This we published a few years ago, and we are planning to replicate that in Apollo, in Vanagaram with mannequins and in the simulation center. So for those who have registered, please do come and join us. For those who are not registered this time, what we hope to run in the next few years. So how do we remember everything that I've said? Utilize the bundle. There is a bundle which is quite easily done and in a unit, and you can remember that quite easily. So in conclusion, ladies and gentlemen, chairpersons, I'd like to conclude by saying GI bleed is an emergency that requires adequate intervention. Pharmacotherapy and endoscopy has significant roles and outcomes. Restricted transfusion seems to have better outcomes, as you've said. Aim to scope them, as Karthik mentioned, usually within 24 hours. Training, as I've shown you, has significant role in improving skills and confidence. Use the bundle, which will aid your decision making. Thank you very much. Thanks, Adam.
Thank you, Dr. Tafik, for an excellent introductory lecture and stressing on the mantra on FBC. And you have set a standard for today's discussion by grouping the evidences used in upper GI bleed. The paper is open for discussion.
Thank you for your kind words, Nidhi. When I see the hand, a microphone of the surgeon, it always gives me palpitations, but I'm relieved now.
Very nice talk, sir. But I have one doubt. I mean,
Yeah.
the forest classification that we use, like
Yes.
2A, 2B, 3, and whatever. So that is for a patient who is not, I mean, which risk satisfies patients who have not been on antiplatelets or anticoagulants. But is there any evidence to say that, well, patient is been on anticoagulants where he is going to be restarted quickly enough in the next 36 hours or whatever? So does it still hold good that the risk of bleed is going to be, we need to intervene in such patients? So, I mean, isn't the risk of free bleed pretty
Okay.
high when they are?
Sticks at the start. That's right.
Do personalized sort of attention to these patients. You may want to use Puristat. You may want to do extra clips in these sort of situations. But there's no randomized trials though to explain. Yeah.
Actually, excellent lecture, sir. I just want what is the duration that is recommended to use PPA post endoscopically in acute bleed, both varicose and non-varicose.
Excellent. Thank you again. The evidence for the non-varicose is 72 hours. The risk of rebleeding is much reduced if you use it. And again, the evidence is not great for varicose bleed, but certainly the usual usage that we use is again 3 days. Because a lot of patients with varicose bleed can actually bleed from us putting in bands, and the banding induced ulceration can cause bleeding. So using PPIs does have better outcomes in these situations, particularly when they are regular attenders for banding. You know, when we were in Leeds, we used to have patients who used to get banded every day. And when I used to go down and have a look down, I thought it's not a varicose bleed, it's actually a ulcer from the banding. And those sort of things you would want to give a longer duration.
Excellent lecture, thank you. You did speak on anti-thrombotic agents stopping
Yes.
when there is a bleed.
Yeah.
Suppose the bleed is very severe.
Yeah.
You didn't say anything about the reversal and how do you do it?
Absolutely. Again, fantastic questions. There are thankfully reversal agents for most of the medications like warfarin, and certain DOACs have reversal agents which we can use, but reversal agents are not available for every single thing. This is why we would stop it, and you would monitor the INR where INR is possible and discuss with hematologists about what is the best that we can use. But certainly you wouldn't use in every single person. You'd use it when the risk of bleeding is high, the risk of mortality is high because of bleeding. The worry is you stop them and reverse, they may get a heart attack, you see. So you don't want to really give them a reversal. You may want to just temporarily stop it unless there's a huge torrential bleeding or the INR in a warfarin person is in 20 or something like that crazy. Again, there's no specific randomized trials comparing them. I think, yeah, we finish off. Yeah, okay.
I think,
No,
thank you so much.
About relook endoscopy. Do you perform any relook endoscopy in any special situation after you have controlled the bleed?
Excellent question. Again, the time that I would relook is when there's ongoing bleeding, which is evidenced by need for admission, if there is ongoing active melena, or if drop in hemoglobin, or if the endoscopist was not convinced in the first time. And again, for a case like what was asked here, someone was on DOAC or something, you do a relook. Thank you. I'm happy to take questions later, but thank you very much.
Thank you so much. Thank
Thank you so much for that, for the lovely talk, and I thank the chairpersons as well. For the second session, I'd like to invite the chairpersons on stage. I'd like to call Professor K. Prem Kumar and Dr. N. Murugan. I'd also like to invite Dr. P.K. Reddy on stage. We have him here today. I'd like Dr. Murugan to please invite our speaker for the second session, Dr. Noor Mohammed. Over to you, sir. Thank you.
Thank you, Karthik. So the next talk is on tools and kits to tackle the bleeder. I remember my days as a registrar in the 90s when we just had a needle and a couple of injections like adrenaline, I think ethanolamine. That's all we had. So we had to tackle all bleeders with very basic tools. So obviously now there are a variety of tools and kits that are available. So Dr. Noor Mohammed is a consultant gastroenterologist at Leeds Teaching Hospital. Obviously, he has an interest in GI endoscopy. He's an honorary senior clinical lecturer at the University of Leeds and the clinical lead for endoscopy services. He's a member of the BSG endoscopy committee and does a lot of courses and publications on the topic. So welcome, Dr. Noor.
Thank you very much for inviting me to chair this session, along with two stalwarts, Chief of Hepatology, Dr. Murugan, and then the Director and Professor of Institute of Gastroenterology, Dr. Prem Kumar. It's a pleasure to know him, that has been promoted just a couple of days ago as the Director and Professor of Gastroenterology. And it's very interesting what I was listening, what we practiced at that time and how much of developments took place in the gastroenterology. It's a really pleasure to see how when we're talking it. I worked at the Northern General Hospital, Sheffield, and then subsequently at the Leeds. And all our job was, if there is a bleeding DU comes, you open them up, undress the vessel and stop the bleeding. And then if there is a variceal bleed used to come, we used to do a vascular ligation of the, devascularization of the stomach as well as the esophagus and stop, or otherwise you do a transection of the esophagus or the stomach high level. But now things have changed in such a way, the role of a surgeon has become less and less. Still more, it's going to be less. And then, as somebody was mentioning yesterday, with the advent of robotics, in due course of time, there may not be much for the physician or surgeon to do. And mostly, majority of the patients and also medical professions will develop some psychological illness because they have nothing to do much. So that's what he was commenting yesterday, I think, actually. So it's a really pleasure to see you, and I'm very happy to meet you.
I'll use it. Thank you. Put it on the slideshow. It's always dangerous to include too many videos. Thank you. Good morning, everyone. Vasu, Mo, and the organizing committee, thank you very much for including me in this fantastic platform. So it's always difficult when we follow Mo in lectures. Now, he's done heavy lifting. He's given all the evidences behind managing the patient. Now, I hope I won't give you any more of these evidences, but we'll try and go practically into the endoscopy room and try and see what we can do with the tools and the kits we have. Now, I do not have any conflict of interest for this lecture, but I have to say I'm hopelessly, shamefully admitting that I don't know much about the endoscopy units here in India. So please forgive me if some of these are quite below par. Now, in preparation for an acute emergency bleed, we need to think about the kit before we get the patient into the procedure room. And the important kit is, of course, yourself, preparing yourself and getting the tachycardia right before you get the patient's tachycardia corrected. Now, the next thing is to get the whole of the unit ready, including your nursing staff, including your portering systems, everything ready in place to get into action mode. The first thing to do is to get your scope ready. When I say that, you have a variety of scopes to choose from. You've got therapeutic endoscopes, you've got diagnostic endoscopes, and I would prefer a therapeutic endoscope with a wider channel. When I say wider channel, the channel size is usually 2.8 centimeters or 2.8 millimeters. And when I choose my scopes, it should be somewhere higher than that so that we can use instruments within the suction channel along with the ability to suction from within. Now that means something around 3.7 suction channel like the colonoscope, but the outer diameter of the scope should be enough for a comfortable, well, rather easy procedure for the patient. Now, there are different endoscopes available. You can choose from single channel or double channel. Double channel helps in 6 directions of movements, whereas single channel helps in 4 directions of movements. It does help particularly when you're looking at treating areas around the top end of the stomach or when you're retroverting. So you do have 6 movements with the double channel endoscope. So unfortunately, Olympus have stopped the double channel endoscopes, and I'm told that this is something in the pipeline they're bringing in with narrower diameter. So much about therapeutic endoscopes. Moving on, then we need to plan for therapy, whether you're considering monotherapy, dual therapy, or combination of 2 or 3. This is for the non-variceal, but for the variceal, you have to consider your second-line treatments and the third-line treatments as well. So you have to have the kit ready in preparation for all these, because you don't know what you're going to find, whether it's a barn door variceal, which is easy to diagnose,
to predict, or it could be an ulcer-related bleed. Now you have other extra kits that are available nowadays with over-the-scope clips, gels, powders, and such that. And don't forget that the banding kit, sclerosant agents as well when we're planning preparation. Now, this is our guru. Both myself and Mo were trained under him. He's a fantastic endoscopist, probably one of the best I've worked with, called Beyond Rumbakan. He has a mantra to say, and that is every bleeding stops. Either you're superbly competent in managing that bleeder, or you're horribly incompetent and patient develops hypotension and the bleeding stops anyway. So every bleeding does stop. So that's Mo's term, that is Beyondism. Now, we discussed about the therapeutic endoscopes. I move forward. Please don't forget CO2 insufflator for all of your therapeutics. CO2 insufflator is mandatory, I would say. It's comfortable for the patients and also quicker recovery. Now have a bleed trolley ready in the unit. So at the very end of the moment, you're not scrambling for the little bits of pieces. They're all in place, labeled quite nicely, and it is readily available for your nurses to pick up whatever you ask for. So this is a very, very important step, I would say. You would have a kit for dilatation, you would have a kit for EMR, you would have a kit for EST, but do have a kit for your bleed. So you have to have this. This is essential. When it is ready, you have everything on display so that you're not struggling for anything. Probably have 2 kits ready. So whatever it is, you have to have a strategy how to deal with this. At the very end minute, you do not need your nursing staff to struggle. And the most important bit here is do not forget your patients. You need to have a comfortable patient who's well informed, who's consented, has considered all other options of not doing anything, going for interventional radiology, going for surgery. All of these are covered in your consent form and signed. Now, the most important thing, as Mo suggested, is to have a well-resuscitated patient who you've timed your endoscopy correctly so that you're not going in early and doing the therapy which is of less significance, i.e. you're not able to cover anything because your stomach or fundus is full of a big clot. So that is the important factor. And remember, correcting factors when the patients are on warfarin or DOAC or anything, those are important factors to consider as well. Now, this I would skip because it's probably not necessary. The important bit about the peptic ulcer disease, my colleague is covering about the non-peptic ulcer disease bleed management following this lecture. So I'm focusing on just the ulcer disease here. So the complications from the ulcer disease are high when you're not considering doing anything. So importantly, active bleeding, ongoing melena, ongoing hemodynamic instability, all of those, and if in deep ulcers, risk of perforation. And also, if left untreated, you do have issues with luminal obstruction in the future. So the stakes are high, so you need to plan your actions. Now, it is also important to distinguish between what is an acute emergency and what is a coffee ground bleeding, which we always talk about. Most important features are hemodynamic compromise that the patient's present with in a massive upper GI bleed, as opposed to the coffee ground vomiting. So we need to be able to distinguish between those, and we have discussed the types, Forest type classifications, and the ulcers do present in various shapes and forms. Now, what is the importance of Forest classification? The importance is about the risk of rebleeding, which is higher in 1A, 2A, 2B kind of areas, but most importantly 1A. Look at the incidences of rebleed there. So that's where your therapy is planned for. The other two, you can sit tight, give PPIs intravenously, and hopefully they will recover. Now, the therapeutic modalities you have are various. There are quite a few of these available in the market, but most importantly, the combination therapy, like Mo mentioned about dual therapy, is important, plus or minus the third modality. First is injection, second is thermal therapy, and third one is tamponading in some way. So that is quite important. That monotherapy is very, very rarely used, and particularly so if I find a Dulaf lesion, I would probably use monotherapy and probably not, or angiectasias. Otherwise, I would go for dual therapy at the least. Not just you want to sleep comfortably, but it is not warranted, not worth the risk of just giving monotherapy and coming out. Now, let's talk about each of these modalities. Injections. Now, if this were to be a bleeding area, the red spot were to be bleeding area, where would you inject first? Now, I would say that is the most, the important area to target for. The other strategy you're using is if your bleeding spot is hidden to you in probably in D1, D2 junction, you want to bring the mucosa, the surface towards you, then inject the distalmost area first to bring it towards you, orientate first, and then address the culprit. But most importantly, this is what we need to remember is the bleeding is coming from not the superficial mucosal vessels. These are coming from the deep submucosal vessels. These are about 1 to 3 millimeters big. And 1 to 3 millimeters on endoscopy, it does look big, but it's important that these are given the utmost respect. Treating adequately is important. And following then, after your initial injection, which provides both vasoconstriction as well as tamponading effect, then you move on to inject the other areas as well. Do not forget that once you have injected into the target area, you've done the job. You've got to come back and cover the whole of the ulcer base as well. Now, what is the evidence of, apologies, I did tell you that I won't quote many evidence, but this is one of them. What is the evidence about using, how much of adrenaline do we use in an ulcer? In a small ulcer, do we need to actually use the whole 15, 20 mil of diluted adrenaline? It's probably not, but the evidence so far suggests that in a randomized control trial, comparing the large infusion of adrenaline versus smaller infusion, the large was based on 10 mils or less, and 10 mils or more. So in this comparative study, they found that a mean volume of adrenaline that is injected should be more than 13 milliliters. So 16.5 was adequately used, but what I would suggest is use your pragmatism, not necessarily in a patient with a recent MI. If you infuse about 15, 20 mils of adrenaline, you will probably have a on-table MI. So it's important to be pragmatic about it, but it is important to see the vasoconstriction that happens when you're injecting so that you're not injecting too much. Now, moving on to clips, we do have hemostatic clips through the scope and over the scope as well. Through the scope, you've got a variety of clips. The most revolutionary step in the clip management is the rotatability of the clips. Previously, as you can, some of you might remember, the clips would not rotate or open and close. It was unidirectional. You do use when the clip is open, it's open. You won't be able to close it. But these are the steps forward, which we are now using. Different lengths of clips and different ways of using these with open, close, and modalities. Now, over-the-scope clips have been in the market for some time. They've been used for various other reasons, including GI bleed. We'll do a bit of work on that in a moment. Now, the advantages of through-the-scope clips are it's easy to use. You've got variety to choose from. You've got different strengths different stem lengths, and also it's less of an expense compared to the over-the-scope clips. But do remember, if you use about 10 clips in management of one single bleeding, it's probably worth considering over-the-scope clips when the cost is same. And if you catch the culprit, your outcomes are better even. Unfortunately, the disadvantage of clips is, again, the choice of clips, in which you have to consider the strength between the two arms, as well as clip position can interfere. If your first clip position is not right on the money, then you will have problems of then maneuvering around those clips to target the culprit. So the first clip is the best clip you would use. Think about the strategy. If a bleeding vessel is around the corner, whether you would want to go for the distal end to bring it closer to you first, or whether you want to just try and approximate the areas on fast. So think about the strategies. And also, slippage of these clips can cause problems with interventional radiology. So for example, if you have applied 4 clips in D1, D2 area, and one of them has fallen down, you've not been successful in managing the therapy, and the patient goes for interventional radiology. So the slipped clip can cause confusion during the interventional radiology when they're doing the procedures. So these are some of the disadvantages. As I told you, there are a variety of clips in the market, but choose based on 2 things. One is the strength of these arms closing together. And the second thing is about the length of the stem that the clip leaves behind. For example, if you have a Shaw clip, which has got a shorter stem, that means your further therapy is not precluded. Your views are still clear because the clip stem is not masking your views. So choosing shorter stem with a strength of the clip which is good is probably one of the best things I would say. Now, I'm eagerly waiting for this clip to come to the market. This has been introduced in American market. It's not been introduced in European yet. It has got jaws, and it can open and close and approximate to edges. Now, moving on to thermal therapy, you've got argon plasma coagulation, you've got bipolar coagulation forceps, you've got monopolar coagulation forceps, and hot biopsy forceps. These would be my choice as well. But for the APC, please do consider APC when it is considered as a mucosal bleed. APC does not have a penetration more than 3 to 4 millimeters. So your submucosal vessels will not be adequately coagulated with just the APC. So please do consider having a bipolar device in your unit, which is better in giving the heat between the 2 arms rather than to the whole surface. That's what the monopolar does, but bipolar does give the heat in between the 2 arms and protects those submucosal fibers, those muscular layer, to prevent deep thermal injury and prevent perforation in future. So when you're using monopolar therapy, there is a need for pinching the vessel, pulling it up, and then applying the heat. But whereas in bipolar, it's not necessary. You can actually press onto the vessel and apply heat. So that's the benefit. I would never use hot biopsy forceps for coagulation purposes, but it is available in the market, cheap and cheerful, but it is dangerous to use, I would say. So the other important bit about the Gold Pro, which is a bipolar coagulation forceps, is that you've got ability to inject from within. So you're saving some money with using this as a modality, because you don't really need an injection, separate injection needle. And these are the monopolar forceps. Now, this is a GI bleed, standard management of GI bleed without any fancy over-the-scope clips or Purestat. So injection of adrenaline, as you can imagine, I'm injecting the posterior aspect first, just to get the approximation closer to me first. And once there is enough of blanching that I would see, I would move on then to apply the hemoclips. Then once hemoclips are in place, again, take time. When you have got adrenaline on board, you've got little time to play with. Now, this is the time when we were using Olympus clips, which did have longer stem. So as you can imagine, this is a stomach, it's fine. But when you're doing similar kind of treatment in duodenum, your lumen is small and you will have issues. So once it is in place, we would recommend using at least 3 clips. Even if one falls, then you have the second one. And then there is probably no need for additional therapy here, but just belts and braces using APC here. That's a standard treatment. But you've got newer clips nowadays with over-the-scope clips and other gels and powders. So where do we use them? So there are 2 types of clips available in the market. One is made by the Ovesco, which has been in the market before the Diagmet produced their clip, which is this here. So both of them have got different mechanisms of action, whereas from the Ovesco clips it's loaded onto the endoscope and it covers it retracts and comes onto the ulcer from the side. But whereas this clip here, it covers from 360-degree angle and then brings in the mucosa closer that way. So 2 different mechanism of actions you need to consider when you're trying to address. So now the views are very, very different when you use over-the-scope clips, because the cap of the over-the-scope clip has got about 17 millimeter length, which is added on to your endoscopic view. So the views are very difficult to see. Here, as you can imagine, this is right on fast onto the duodenal area, which is right in the duodenal bleed, which is the artery is seen right there. You have to just assume that is the case. Sometimes the cap is covered by the mucosal plugs. It's difficult to wash out. So be prepared for these kind of challenges. So that's the area you're targeting. You're on fast onto the area. You're suctioning enough to bring in the ulcer within the cap, and then you're applying. Try not to pull with the forceps. You can apply gentle pressure, but I would say not. And the company doesn't recommend pulling as well. So once you're suctioned, you've then applied the clip, and that covers the ulcer and the little artery which was bleeding. Now here is an example of how to use the bipolar. How to use the bipolar device as well as use the over-the-scope clips. So you have to identify the bleeding area, press onto it, apply 20 to 30 watts, whichever, depending on where you're treating. More heat in the stomach is fine, but less heat in the duodenum. Once you're satisfied, you then think about what next. So here, this patient has re-bled after the interventional radiology, and you can see the coil coming out from there. That's the coil, interventional radiology coil. It's almost like a full thickness perforation there. So we then managed it with suctioning and application of over-the-scope clip, and then managed to stop the bleeding. So we do have gels and powders. The most important interventions into the endoscopy unit was when hemospray was introduced by the Cook team. And then followed by that, we've got Next powder, which has been introduced last year, from Medtronic. Both have similar course of actions. It covers onto the surface. It's a synthetic powder which provides the hemostasis onto the surface. Now, here is an example. So this is a bleeding area from within the proximal part of the stomach. You've got to, the most important part of using hemospray is to clear the channel with just the air, not with any droplets of water. Once you have droplets of water, unfortunately, then it becomes, it's easy to clog the channel. So be careful that the particles can cover your lens. So you have to identify the area first, ready to use, and ask your assistant to start pumping. So once the canister is being pumped, you will lose your visibility. So be careful and be ready on fast onto the area. Now, this is a video of torrential DU bleeding. We've injected first with diluted adrenaline. You've identified the area, and that's the bleeding area right there. It's tempting to do, the standard treatments with thermal therapy and injection of adrenaline. What we're doing here is to apply pressure with bipolar forceps enough to see the coagulation work, enough to see the blanching of the vessel. Now, once it is fully blanched out, you might see that there is necrosis or thermal damage onto the sides as well, but that's fine. You've focused your treatment across the area. That's how it looks after treatment in duodenal areas. Duodenum, both in duodenum and the stomach, blanching from adrenaline can scare you, but it's, even if it is diluted adrenaline of 1 in 10,000, couple of mils will give you a lot of blanching, but that gives you time to act with other modalities. Now, what if you go and see a large clot? What can you do? Because you're not able to dislodge this clot. Do you come out without doing any treatment, or do you want to take the clot out and do the treatment? How many of you think that removing the clot will be helpful? 2? Okay. What would the others do? Leave it alone with PPI cover? I would not do that. I would actually remove the clot. And removing clot is quite important because you need to expose the base and see what is happening. This is a fresh clot and there is a bit of ooze as well there. So what you need to do is to try and remove the clot. You need to apply, try and see if you, with the cap of your on your endoscope, try and remove the clot on its own. If it doesn't work, then you need to have snare out, snare the clot, remove it, expose the base, identify the culprit there and then, and do the therapy. Otherwise, you will be awake middle of the night to treat this patient again. Now, use of RDI. I'm sorry, I don't have a video of an upper GI use of RDI. This is a red dichromatic imaging from Olympus, which is in the new series of Olympus endoscopes. It does help in identifying the bleeding spot when your white light imaging completely reds out the screen. So if you switch on to the red dichromatic imaging, so this is an unedited video of EMR that I did, and then you have a torrential bleeding points. 2 of those arterial bleeds. It takes literally seconds to identify where the bleeding is coming from. This kind of bleeding, if the patient is seeing, will actually give them palpitations. So, but whereas this has got a calming effect, and it doesn't give you the tachycardia as well. So you identify the area, go with the coagulation forceps, target them. This is the monopolar coagulation forceps. So gentle pull once you have held the coagulation forceps and applying soft coag, 4 and 80, 4 and 50, between 50 and 80 should be fine. So use constant flush to keep the surface clean. another application of thermal therapy is sufficient to control the bleeding. So use RDIs if you have to target bleeding in upper GI endoscopy. And do not forget CAPs. CAPs do play a vital role. Use of Purostat, again, Mo showed a brief video. I will try and avoid this. Coming to Purostat, it is a matrix, which is a viscous fluid, which you inject through the special catheter. It forms a gel on the surface and it stays there for about 24 to 48 hours. So it does help in managing the bleed. It does help you sleep better. But the role of Purostat is still debatable as to where it fits in. If you manage to control the bleeding, fine. If you do not manage the bleeding, then the patient is going for IR. Where is the need for Purostat? It is still to be established, but it does have a role when you have a persistent niggly ooze. Now, what is this pathology? Duolar, yes. This is one of the areas where Mo said we use PPI therapy before the upper GI endoscopy. These are the pathologies which get masked during the PPI therapy, but it's fine. If you identify these areas, all you need to do is apply one clip. This is probably the only time when you use one monotherapy to control the upper GI bleed. So once it is done, it's nice and straightforward. You may need to inject some adrenaline if you have a bigger vessel, but one clip should be sufficient to deal with this pathology. Now, last couple of slides. These are the golden nuggets I follow. Profile your patient. Like Mo said, use Blatchford score, use your Rockall score to predict the mortality, and apply clinical nuances, what you have. Now, the other important bit to remember is in elderly comorbid patients, not doing anything is also an option. Sometimes the mucosal bleeds stop by themselves. So it's important to consider masterful inactivity, do nothing, and carefully discuss with your patients. It's not necessary to jump into action every time you see a GI bleed. So hemodynamic stability is really important. Stabilize the patient and then consider upper GI endoscopy. Adequate resuscitation with restrictive bleeding protocol is really important. Now, carefully consider the transfusion in patients with post-MI, and also consider reversal agents in patients who are on warfarin and DOACs. Now, the other important bit is do not wait for the blood results to come back to satisfy you before you do the endoscopy. It's important once you have the correcting factors in, try and act in an optimal time. In conclusion, ladies and gentlemen and chairperson, upper GI endoscopy, I think, is fun and it is also challenging. It is rewarding for yourself and it is rewarding for the patients too. They will thank you forever for saving from interventional endoscopy, interventional radiology, or from a big, massive surgery. Now, preparation is key, as we discussed, and keep your interventional radiologist and your surgeons informed about the GI bleed when it comes in, or keep them in the standby. Thank you very much.
Thank you, Dr. Noor, for the excellent coverage of about all the modalities available. One question from Dr. P.K. Reddy.
Professor Noor, I just want to ask one small question. You mentioned about the sprays. When a gastroduodenal artery is bleeding, it bleeds in two ways normally. One is intermittent spurts or a continuous spurt, continuously. How does the sprays will work in those circumstances?
GDA bleeds are really, really difficult to manage.
Right, okay.
To be perfectly honest, if you've not achieved hemostasis in the first few minutes, then you might as well put a clip, come out for interventional radiology to address where the therapy should be. Now, the most important thing I would say is if the patient is hemodynamically stable and comfortable, i.e. whether the patient is under general anesthesia or sedation, if the patient is comfortable and if you have time, then try and use all of your modalities. More recently, the data is suggesting that use of over-the-scope clips in these kind of areas is sufficient to tackle 2 or more areas of bleeding, whereas with the through-the-scope clips, you're targeting one particular area. So if you have space, then you can use the over-the-scope clips. But I find it really challenging when you have a torrential bleed like gastroduodenal artery bleeding, then trying to use over-the-scope clips is quite challenging.
Other small question is, you said only 2 people have raised their hands in not to disturb, in the clot formation, whether to remove the clot. I agree with you that when you remove the clot, you will see the vessel clearly and then you can deal with it. But the normal thing is, there is a clot, bleeding has stopped, there is no fresh bleeding. We'd like to wait and see rather than disturb the clot and make the blood vessel to bleed again. So both ways you can talk, of course.
Absolutely, absolutely. I think what the point I was trying to make there was with a fresh clot and with the ooze around that area, you probably need to act. But if it is an old clot and if it is completely adherent to the area, not want to disturb. But in that particular video, yes, you would want to remove the clot and you would want to see the bleeding. You would want to make a decisive action plan there and then. Thank you.
Thank you, Dr. Noor. We close the session to be out of time.
Thank you so much, the chairpersons as well as the speaker. Due to want of time, we'll take some questions later during the coffee break, if there are any. I'd like to move on to the third session. I'd like to invite the chairpersons, Dr. G. Loganathan, Dr. M. Hariharan, and Dr. Nandakumar on stage, please. I request Dr. Loganathan to please kindly introduce our speaker, Professor Khalid Zakaria, for the next session. His talk will be on small bowel odyssey.
Good morning to all of you. With thanks to Dr. KRP, the organizers and organizations that are involved in this activity, I am very happy to invite Professor Khalid Zak, who is the Chief Executive Officer of Al Safwa Hospital in October City, and he is the endoscopy training lead, Egyptian Society for Gastroenterology and Hepatology. He trained and practiced in UK for 18 years. He has over 65 journal publications to his credit. He is also the founding member of the UEG Young Talent Group. He has special interests, which includes interventional endoscopy, ERCP, IBS, and IBD. Zach is currently focusing on training the young generations of gastroenterologists as well as healthcare management. Happy to.
Thank you. Hello, everyone. I'd like to thank the organizing committee for inviting me here. It's my first time in India and hopefully not the last. I thank Mo for choosing this lecture. And I'd like to remind you that the end of this lecture is the coffee break, so don't be worried. The small bowel issue is a very difficult issue. It's a very boring issue. You can spend your whole life as a gastroenterologist and never deal with the small bowel because there's always someone in the department that you hate. And this someone deals with all of the small bowel issues. So yes. So the small bowel bleed is basically anything that is causing a GI bleed from the ampulla of Vata to the ileocecal valve. And although it's not common, it only contributes to 5 to 10% of the whole GI bleeds, but it is the primary cause of an occult GI bleed. It is very challenging to manage, and although we do have a lot of new modalities for diagnosis and management, we still do not find the cause of the bleeding in about 1/3 of the patients. So we talk about etiology, it can be divided according to age to start with. So under the age of 40, it's usually either Crohn's disease, a urofoil lesion, any small bowel tumor, a macula reticulum, or one of the polyposis syndromes. If we're talking about older than 40 years, then we can talk about angiectasias, NSAIDs-induced ulcers, again, a urofoil lesion or a small bowel tumor. So what are those small bowel tumors? Well, they could be benign, they could be malignant, or they could be a very rare manifestations by a GI bleed for one of the polyposis syndrome. So the benign lesions are a small cyst, a benign small endocrine tumor like a small carcinoid, a hemangioma, an adenoma, leiomyoma, lipoma, and urofibroma. The malignant, the most common one is the malignant neuroendocrine tumor. They usually proximal and the small bowel, an adenocarcinoma or a lymphoma, which are distal, and a large cyst or a sarcoma, or a secondary from a lung or a breast malignancy. And again, it could be a rare manifestation through a GI bleed of one of the polyposes like Peutz-Jeghers, FAP, and general polyposis syndromes. There are a lot of other causes that are minor and rare, but we should keep them in mind. Diverticuli, varices, TB, drug-induced, infection-induced, amyloidosis, autoimmune, the list goes on and on and on. So the clinical presentation of a GI bleed, this could be melena, or an occult GI bleed, which is no melena, but it's a heme positive stool test, or just an iron deficiency anemia. In rare cases, it could be it could symptomatize as hematemesis, but if the bleeding is very proximal, and it could be in the form of hemochasia if the bleeding is very distal and very fast. So the patient can have abdominal pain, can have constipation, can have diarrhea, can have anything really. There are constitutional symptoms which are usually related to the underlying cause of the GI bleed. And depending on the severity of the iron deficiency anemia that is associated with the GI bleed, we can have the symptoms and the signs of anemia. And there could always be a certain characteristic of the patient that he's having recurrent anemias, recurrent blood loss, recurrent blood transfusion, which is very typical of the small bowel bleed. Again, there are certain clues that we need to look at. So in the drug history, if the patient is on a non-steroidals, we should think about non-steroidal induced ulcers. His personal history, if he has aortic stenosis, think about Heide syndrome. If he has any form of cancer, if there's a family history, an early colorectal cancer or endometrial cancer, any hyperpigmentation should indicate to look for a Peutz-Jeghers syndrome. Any telangiectasia, again with the hemorrhagic telangiectasia, any itching or an issue with a blistering rash, could think about dermatitis herpetiformis, and the list goes on again. So how do we investigate it? So the whole idea is how to look through all those meters and meters of the small bowel that you can't physically reach. So you have the wireless capsule, you have the push enteroscopy, you have the device-assisted enteroscopy, you have an array of imaging from CT to MRI to angiography to radio-labeled scans to surgery. So when we look at the capsule, it was FDA approved in 2001. There are so many types in the market, but on the average, you can take up to 57,600 color pictures over a period of 8 hours. It can detect very subtle mucosal changes that you cannot be that cannot be seen by other sort of imaging modalities. It has a certain sort of an intervention window that it should be done in the first sort of 14 days of the presentation with a chronic overt bleed, or up to 3 days of the presentation with an acute bleed. The BSG guidelines recommend that we do a bowel prep before the capsule with 2 liters of PEG and have some simethicone as well. And there are guidelines about taking some prokinetics before the procedure as well, if the gastric emptying, or actually during the procedure, if the gastric emptying is delayed more than 1 hour by the real-time viewer. That is one of the pictures that you could see through the capsule. There are some false positive and some false negative images. So people who look at the wireless capsule images are aware of this. The first one here is a oops. Yeah. So where's the pointer? Yeah. Where's the laser? So yeah. No? Anyway, so makes sense. So that's the bleeding point. That's another telangiectasia. That is actually a false a positive bleeding point because that's an air bubble, and that's a false negative point because that's actually an ulcer. So it is a huge learning curve in understanding how to manage and diagnose and write a report for a video capsule. The push endoscopy, again, is a very laborious, very old technique. It used to be very useful before the invention of the wireless capsule. It is a long scope, 2.5 meters length, or you can use a pediatric colonoscope or a normal colonoscope if you're aggressive enough. The implications of using it were very limited by the excessive looping. So you can then use an overtube, which stiffens it more. But again, in the best hands and in the easiest patients, you can just go about 1.8 meters deep, and that's usually wasn't enough. But it is helpful for those 1.8 meters, and you can do some intervention. You can do tattooing for the surgeon. The device-assisted endoscopy is actually a lot of fun, but again, not for everyone. So I attended the list for the double balloon endoscopy in Bristol. It was torture. Single balloon endoscopy is even worse. But the spiral is fun. And that's why Olympus bought it and is now selling it for a lot of money. So the double balloon was invented in 2001, the single balloon in 2006. The two of them are bidirectional. You can do them antegrade from the mouth or retrograde from the anus, and then you meet in the middle and you hope that you overlap and you do a complete small bowel exam. The rates of completion of the test are higher with the double balloon, almost 3 times. But most of the papers that put them against each other show that there's no significant difference between the two procedures when it comes to actual therapy value and diagnostic value. As I said, the spiral endoscopy is there's a lot of work that's going to happen there. It used to be an overtube with a corkscrew and used to sort of, entangle the bowel into it and shorten it. And now it's been reintroduced as a motorized function, and I expect this will revolutionize not just the small bowel endoscopy, but actually colonoscopy in the future. CTE or CT enterography is a very useful value for any disease, any bleed related to a vascular lesion. So it can detect any sort of anomaly in the vascular array itself. It can detect angiectasia, any arterial lesions, any venous lesions, and it's also useful because it's a CT, so it can give you some idea on the inflammation and the neoplastic condition of the small bowel. This is, for example, is an image of, this is a normal CT showing an angiogram. Sorry, this is the arterial phase showing a lesion here. This is the angiogram showing the spermocenteric artery with the dilated artery and the nidus. And this is, for example, is a retrograde double balloon endoscopy showing this elevation with the telangiectasia on the top. This is a CT, no, this is a chest X-ray showing a cyst formation and consolidation in the lung, and a double balloon image showing the concentric narrowing and the ulcer of TB enteritis. Again, this is a CT showing a malformation, AV malformation in the lung, hamartoma in the liver, angiectasia in the OGD, and angiectasia in the double balloon. And this is the lesion showed by CT, followed by a barium enema, and the nice polyp is obvious in the double balloon. Again, more modalities of the video capsule with the bleeding point here, telangiectasia, 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 with the different modalities between type 1 and type 4. This is APC of a telangiectatic lesion. This is in the stomach, but it does look the same in the small bowel. So MRI is very helpful in normal in other pathologies. I use it a lot in the Crohn's disease, but it can help. It does detect any sort of mural thickening more than 4 millimeters, but it mainly helps if the cause of the bleed is Crohn's disease, an adenoma, a lipoma, or a polyp. And it can show some malignant conditions. The bleeding scan is a nuclear medicine scan. It's done by injecting technetium labeled red cells. It can detect the extravasation of the red cells at a rate of 0.1 mil per minute. It's very highly sensitive, and it can locate the exact location of the GI bleed in 52% of cases. Now, the Meckel scan, which is obviously for the Meckel's diverticulum, it uses the same modality. It's a radio-labeled scan, and it can show where the Meckel's diverticulum is because of the ectopic gastric mucosa that is associated with it. And in children, it's the first line of testing for such issues. A CTA, well, a CTA is done in patients who have a less brisk mid-GI bleed. It can detect the bleeding site where the rate is more than 0.3 mils or more. However, it is an exposure to radiation, so it has its limitation with the dye, renal function, pregnant patients, and so on. The conventional angiogram is helpful, but again, it should not be your first line. There's a risk of a small bowel infarction from the embolus, but it has a very high detection rate, and it can also detect Meckel's diverticulum itself and other forms of portal hypertension. The gallium PET CT is the best scan for the small bowel neuroendocrine tumor, but mainly if it is a somatostatin receptor positive, Otherwise, it won't be helpful. You have to do a CTE. An intraoperative endoscopy is the last resort when you can't find what's going on. So you just put the patient to sleep, open him up with a laparoscopy and put the tube in, or make an opening and an enterotomy and put the scope in. And again, it's very humiliating because the surgeon always sorts it out. So, management. Now, these are all the causes. So imagine what the management is like. This is why we leave small bowel bleeds to the most hated person in the department. So a systematic approach is essential. Okay, first of all, most of the countries have different modalities. So like upper GI bleeds is simple, lower GI bleeds is simple. Small bowel bleeds, the Americans are different from the Japanese, the Brits are different from the Europeans, the Asians are different from the Chinese. It's a mess. But initially, you have to prove that you've done an upper GI and a lower GI endoscopy and they're negative. And then you have to prove that you've done it again, because the first one could be wrong and he missed a lesion. So you've done this and you've done that. You need then to think on two levels. Is the patient stable or the patient is not stable? And if he's having an occult bleed or he's having an overt bleed. So based on this, your first line is usually a capsule endoscopy. If the patient is very unstable and it is overt, then you go to a CTA. So after you've done the virtual, the wireless capsule, and you've isolated the site of the bleed, then you can do a device-assisted enteroscopy and sort it out. If it's negative and you can't know where it is, then it's based on how much damaging is that bleed. If it's really severe and you can't wait, then you go to the next phase and you do a direct assisted enteroscopy, or you do a CTE, an MRE, or even the laparoscopy. If the bleeding stops, then it's fine, do nothing. If the bleeding continues, but the patient is okay, then you can just follow them up with regular sort of CBC, monitoring, and so on. So, and then repeat the cycle if it gets worse. So if you put this in an algorithm, this is the ESG society one. So based on the fact that you've done the upper GI and the lower GI, and you've actually made sure that it's done, so for the second time, if it's an occult bleed or an overt bleed, if they're stable, you go for a capsule. If they're unstable, you go for a direct assisted enteroscopy from the start. If the capsule is negative, then you just wait and see. If the capsule is positive, then you do the direct assisted, the device assisted enteroscopy, and based on the findings, you can do other things. If there is a recurrence, you can consider again the video capsule or intervention, and then a specific management. So it's basically a capsule, find something, try an endoscopy, a capsule, find something, try an endoscopy. Now, the Japanese are a little bit more proactive and they have more money. So every patient gets a CT first. Okay. So again, they have to make sure that you've done the upper GI and the lower GI, but then everyone gets a CT. And if you're in a hospital that doesn't have a CT, you'll be in trouble if you don't refer the patient within a few weeks to another hospital to have the CT done. So the CT is important to rule out any other issues. And then if that's normal, you go into a capsule and you go into the balloon assisted enteroscopy. I like this one, but it's more expensive. So that's the general management, if it's an ulcer, if it's so. But what are, the other issues that we don't usually deal with? So there are other causes that we said, for example, like telangiectasias. So telangiectasias are one of the most common causes of midgut bleed. So, and the treatment choice is ablation, but you have to get there. So through a DE, and hopefully you can get there. If you can't get there, or the patient can't have the endoscopy, then thalidomide is a good option, and octreotide is another option. If it's a non-steroidal induced ulcer, you stop the non-steroidals, you do an endoscopy with or without embolization. And be careful about PPIs. People give PPIs when it comes to NSAIDs because he might have something in the stomach as well. But then there are some studies about dysbiosis damage, and it actually increased the damage of NSAIDs induced instant ulcer, but that's still in research. A uniform lesion, again, endoscopic intervention with argon plasma coagulation, hemocleoporin injection, and angiography, and eventually surgery. Small bowel varices, endoscopic angio, tips, and surgery. If it's a small bowel neuroendocrine tumor, surgical resection. If it's local regional, if it's widespread, then long-acting somatostatin analogs. If it's an adenocarcinoma, surgery and chemotherapy with the checkpoint inhibitors. If it's a GIST, surgery and tyrosine kinase inhibitors, non-GIST surgery. And the benign tumors are all between endoscopic and surgical resection. If it's a metastatic tumor, the small bowel, then it's a palliative treatment. If it's a mecus diverticulum, surgery. We all know how to treat Crohn's disease. So from endoscopy to embolization, when it's a bleed, to immunotherapy and immunomodulation and surgery. And ulcerative jejunal ileitis due to celiac disease, again, surgical resection of the ulcerated segment, steroids, elimination diet, and TPN. So the take-home messages is, first, don't go into small bowel, avoid it. But mid-gut bleeding is common. It's common because it does come up to 1/10 of our daily work, but it is very hard to manage. The capsule endoscopy and the imaging studies have made the diagnostic evaluation much easier, but it's still difficult than before. The device-assisted endoscopies are nice, but they're generally done for intervention. They are expensive. They need a lot of training. They need a lot of time. They take a lot of the list. And again, they need more equipment and more training. The interventional radiology and surgery are required if there is massive bleed or we fail to control it through the endoscopy. And after achieving the hemostasis, you should make sure that the underlying situation is identified and dealt with and managed. And again, the patient age, the comorbidities, the pros and cons of the procedure, the radiological and the surgical interventions, and their access should be considered. Thank you very much.
Oh, thank you, Prof. That was an excellent lecture.
Thank you.
Just two questions. One, after the first failed capsule endoscopy, when the protocol says that you have to go for the next one, if at all, if the bleeding continues. But what's the pickup rate on do you quite often do a second look capsule endoscopy, and what's the pickup rates like?
Well, it depends why the first one failed. So failed capsules are either physical failure or manufacturer failure or bad reporting. So if in Crohn's disease, for example, they could get impacted, so don't use them. In delayed gastric emptying, they stay in the stomach for 3 to 4 hours. So if all of this is fine and it has not been stuck anywhere and there's no problem with the mobility and it just didn't get good views, then, and you've done the PEG, because if you've done the PEG, if you've given the prokinetics and there's no physical barriers, it's very unlikely that you're going to get a good report. And especially with all the new technology and the location, the report comes up and tells you this bleed is like, 2.5 meters from the mouth. And so it's very straightforward. So I would repeat it again another time before deciding to go through a device-assisted endoscopy, because it's very laborious and it's not readily available.
What's the pickup rates like? Have you on a second look capsule endoscopy, have you picked up anything extra? The other thing is that I find it a problem when particularly when the small bowel transit is too fast. When it's too fast, I just miss it. There's nothing like recently, about few days ago, we did a capsule where, it went through the, like, in 1 hour, 20 minutes, I could virtually see the cecum.
God.
So it was, in such cases, I don't find any this thing, unless otherwise. The other thing is that here the capsules are expensive.
Yes.
So I find it little difficult asking the patient to go for a capsule again.
No,
So-
if you're asking anecdotally, I rarely repeat a capsule as myself. But unfortunately, the guidelines for that are very sparse, and the papers, you'll find success rates in some papers of like up to 90%, and in the other ones as like 5%. So again, and there is a lot of a different sort of qualities according to which cam you use. So it's still early to get an exact rate and decide upon it on your normal algorithm. And plus, most of the readily available capsules in the market now are the capsules that you actually have to fish out after you do the test. And sometimes they're lost. I've had a patient that had to do, surgery on his bathroom to get the capsule because it was cheaper than repeating it.
And the last one, just on the specifics of management, you didn't mention, the thalidomide. For vascular thalidomide for vascular ectasia, how long do you use in your clinical practice when you see vascular ectasia? Just give it for 3 months and then follow them up, or what's your longest period that you have given thalidomide for?
I think the longest period I've seen a patient in our care on thalidomide in telangiectasia was 2 years.
2 years.
Yes.
Do you get peripheral neuropathy? You got any problems with peripheral neuropathy in such patients who have been used long?
I think the cohort of those patients are usually old with low mobility. We usually start them on thalidomide and they disappear.
Can I just ask you if you have any experience with capsovision?
With what, sorry?
The capsovision, the other capsule from the German, the capsovision.
No.
No. Thank you.
Okay. Thank you.
Thank you, one and all.
Thank you for the talk and thank you to the chairpersons. We'll just take a short 10-minute coffee break and we'll be back for the next session after that. Thank you very much. We'd like to start with the next session. For the fourth session, I'd like to invite the chairpersons on stage. We have Dr. B. Mahadevan, Professor Ashok Chako, and Dr. Venkatesh Munikrishnan. I'd request Dr. Ashok Chako to please kindly introduce our speaker for the fourth session. Dr. Adolfo will be speaking on lower GI bleed, when to intervene.
Thank you very much. We go on to the next session. As you know, there is a lot of information available on upper GI bleed, a little less on midgut bleed, and also less on the lower GI bleed. There are very little RCTs. Most of it is cohort studies and retrospective studies. So it will be quite interesting to hear from Dr. Adolfo Parablanco about when to intervene in a lower GI bleed. Dr. Adolfo is a consultant gastroenterologist at Nottingham Teaching Hospital, and he has an interest in GI endoscopy. He is also an honorary senior clinical lecturer at the University of Nottingham and the Trust Clinical Lead for Endoscopy Services and Endoscopy Training. He is the recipient of several awards and grants related to endoscopy teaching and training. He supervises PhD and postdoctoral students. He has been a faculty of several national and international endoscopy training courses and has several peer-reviewed publications to his credit. We look forward to what you are going to tell us today. Over to Dr. Adolfo Parablanco.
Hello, good morning. Thank you very much for the kind introduction, and thank you very much to the organizers for inviting me to be here. This is my first visit to India, and I'm really happy and proud to be with you. And congratulations for the meeting. I think it's been very, very informative. So this is a topic that is probably not the most common or easiest one to deliver, but I really enjoy it because it's I like the difficult cases also in endoscopy, and there's a lot we can do about lower GI bleeding, and I hope that after this talk at least we have some more ideas about what to do and how to do it. So first, we have to define what is lower GI bleeding. Until now, not many years ago, it was considered as the bleed coming from beyond the ligament of Treitz. However, with the advent of new techniques to investigate the small bowel, now capsule enteroscopy, so there's a mid-GI bleeding, which comes from the small bowel. So lower GI bleeding could be considered as that one coming from beyond the terminal ileum. And traditionally, we've been listening to talks about very excellent talks about the upper GI bleeding, and upper GI bleeding has probably been considered more important because we do more cases treating endoscopically as well upper GI bleeds than lower GI bleeds. However, and also from this important study from Professor Lanas in Spain, over a 10-year period, they investigated the upper GI bleeds and lower GI bleeds, and they could see a reduction in the cases of upper GI bleed with an increase in the number of lower GI bleeds. And it's not just the numbers, but the importance of the cases was also highlighted. So that, for instance, as you can see in yellow, the death rate of lower GI bleeds was greater than in upper GI bleeds, almost 9 versus 5%, more days of hospitalization, more procedures required for the investigation. So and the patients had more comorbidities. So usually it's elderly patients with comorbidities who have more lower GI bleeds and who do worse. And this interesting audit also from the UK, Dr. Ogland and co-investigators. There is an audit over 2 months where all the cases for lower GI bleeding, more than 100 centers were included, more than 2,000 cases. So the main cause for bleeding in the Western countries is diverticular bleeding. In 1 in 4 cases, approximately bleed from diverticula, which is a problem because usually diverticulas, there are many of them, and we have to find where the bleeding is coming from. And then anorectal bleeds, mainly hemorrhoids, which usually are not given much importance. However, they may be the cause for severe bleeds and severe reduction in hemoglobin. And then we have colitis, which more usually diffuse bleeds, although they may come as well from definite ulcers. And sorry, you can see the slide right now. And then a few cases come from the small bowel, and at least 20 to 25% of the cases remain undiagnosed, which is a problem. Sorry. So there are other series as this review in the New England, where they did a review about the causes for lower GI bleeding. And again, in Western countries, it was a diverticular bleeding, but there were many more other causes analyzed. And we have, of course, angiodysplasias, post-interventional bleeding, such as polypectomy, radiation proctitis, and stercal ulceration in the rectum, which is an important cause for bleeding in patients. So you know very well about diverticular bleeding. So we have to find the right diverticulum that was bleeding. Sometimes it's very difficult because there is lots of blood. And then we have vascular lesions such as angiodysplasias that can be treated. There are different ways of treating it. The methods for treatment, we'll review them briefly, but in many ways are very similar to what Dr. Mohammed has described for upper GI bleeding. So epidemiology is important, of course, and it's not the same causes in every country. So in China, for instance, it was approximately 15% of the cases of acute lower GI bleed which showed diverticular disease in this study, where they included retrospective cases and also more than 50,000 cases analyzed in a systematic review. And in this series in Sudan, I'm very sorry for the connections. In this series in Sudan, it was 15% of the cases with diverticular bleeding. In China, sorry, it was 4% only. So there's something in the epidemiology, of course, that makes a difference. I have another one, maybe. Okay, I'll try not to. Can I pass the slide from here? No. For this one, maybe I won't touch anything there. No, but this requires a memory. Okay, then I will very carefully advance. Okay. So, but epidemiology, lots of causes, most frequent diverticular disease, but depending on the country, maybe something different. Stay there, please. And so what about management? Of course, bleeding is bleeding from wherever in the body it comes. So Dr. Tawfiq described very well what is the most important thing. What is the most and first thing? Can we remember, everyone? A, B, C. Okay, so that's very, very, very well delivered message, Mom. So it's the same here. There's bleeding. In fact, we may think that it's a lower GI bleed and it may be an upper GI bleed. So things are not so clear. Stand behind. And it's never too much stress how important it is to do a proper medical history, especially for our students and young doctors. Proper, because you're like Sherlock Holmes, so you may identify what's the factor telling you where you have to direct your scope or your CT angiogram or interventional radiology. Physical examination, again, nowadays, now with COVID, we do a lot of telemedicine. Here you have to see the patient, certainly, and understand what the problems are and do a proper physical examination. And the anus shouldn't be obviated. We have to do a proper rectal examination, see if there is any bleeding material, and check if there's any benign or malignant anorectal disease. Laboratory, and mainly, but not only to find what's the urea and creatinine relation and see if it's telling us that it's an upper or lower GI bleed. And there are risk scoring systems that we will briefly review. So about the management, we've seen, and we'll talk a bit later about the restrictive strategy for the blood transfusion. And this is important. So the same as we have risk scores for upper GI bleed, there are some risk scores for lower GI bleed. And anybody here is using any risk score system for lower GI bleeding? I mean, it's okay if you say no, because even in the UK, where this score system was described, they didn't know it, and only 25% of the hospitals were using it, and probably was less than that. But it doesn't mean that we shouldn't be using them. So just go, there's these slides that show that the studies have been done where different risk factors for different types of outcomes, like severe recurrent bleeding, in hospital complications, adverse outcomes, or mortality have been reviewed. And there are many factors that most of them, and with common sense, you can suppose, such as the medication, NSAIDs, antiplatelets. But the symptoms, if the patients don't have any symptoms, usually they bleed from non-inflammatory conditions, which tend to bleed more. Physical examination, patients who are have a shock, they do worse. And it's important. So in terms of mortality, there is an increased risk of mortality when there's rebleeding, when ischemia is the diagnosis, when there are coagulation defects, when the patients need a transfusion, when the patients need intervention, and when the bleed happens in inpatients. So when it develops in a patient who was already an inpatient. And we know well that these patients are more comorbid and they do worse. So this is a study where they compare the outcomes of lower GI bleeding in patients who develop the bleed as outpatients or inpatients, and they could find differences in the poor clinical course. So 50% did poorly, and that doesn't mean that they died, but they had rebleed, they needed transfusion, so on. 50% compared to 20% of the outpatients. Also about the need to receive an endoscopic hemostasis. Many more patients of the inpatients require than the inpatients. And importantly, 2% of the inpatients died in this series. So if we have an acute GI bleed developed in an inpatient, usually they have worse outcomes, and we need probably to intervene more there than in outpatient. So about risk scores, there's a couple of them. I won't go through them, just want to tell you the names of them and what they do. So usually they check the patient's history, some of them blood tests, albumin, creatinine, hemoglobin, clinical, the outcomes, if they were using medication. And the OROC, as you know, is the area under the curve. So it means how precise, how accurate the score was in predicting those outcomes. So anything above, let's say, 0.7 is considered good. So this is the Oakland score, which includes variables as age, gender, previous lower GI bleeding with admission, what we found on the digital examination, the rectum, heart rate, the blood pressure, systolic blood pressure, and hemoglobin. And this score proved to be good to determine the patients who could be discharged safely. That means with no patients with no rebleeding, no need for transfusion or for therapeutic intervention, who didn't die in hospital, and who were not readmitted within 4 weeks. However, those who had a score more than 8 points in the score, they were considered with major bleeding and they would be admitted. So 8 or less could be safely discharged with high accuracy of prediction of who those patients were. More than 8, they would be admitted. Another score, ABC, but this is not the ABC that we were talking before. It's about age, blood tests, and comorbidity. This study was published in Gut compared with other scores, and also proved to be good with an area of 0.84, which was superior to the other scores, and they consider low risk up to 3 points and high risk of 8 or more points in the score. So there are some scores, some of them have proven to be good. Nothing is perfect. Importantly, none of these scores have been compared with a clinical judgment in randomized trials. Therefore, clinical judgment is still important. We still need the humans and the doctors to see what everything put together, the physical examination, the clinical history, what the patient looks like, needs to be done according to that. So clinical judgment, but scores some of them are good. And in this is the only meta-analysis including these scores published in JAMA, and they found that the Auckland was the one, which is the British one, could predict with greater accuracy the safe discharge, existence of major bleeding, need for transfusion, and it was not so precise for hemostasis. So we have already seen about the need for strategy restricted in transfusion or not. These are, I just want to include this to recommend you this paper. The Dr. Villanueva, who was the first author of the randomized study in the New England, is one of the members of this study with recommendations, also with chemotherapy societies involved in Spanish gastro societies. But in summary, healthy patients, the target is 7 grams of hemoglobin for transfusion, and we should keep 7 or more. And in patients who have a heart disease mainly, but not only, our target should be to keep the hemoglobin at least in 9, because there's an increased risk for adverse cardiac events. So endoscopy, we know it's usually the best tool in patients who can have a colonoscopy, which is not so easy because we need to clean the bowel. As compared to the upper GI tract, we need to clean the bowel. And we know how difficult it is in a patient who's not bleeding. So in the past, it was advocated that colonoscopy could be done in patients with lower GI bleeding without any bowel preparation. I don't know what you think of that. They said because the blood itself was a type of bowel preparation, but some studies showed that many cases the lesions were not detected. And of course, we know that there's a risk of explosion in the colon whenever we have to apply any type of electrosurgery. So nowadays, colonoscopy for lower GI bleed without bowel preparation is not recommended. So the bowel preparation, I don't know which is the most frequent method for bowel preparation in India, in Western countries, mainly still polyethylene glycol, and especially high volume preparation solutions are better. Even up to 12 liters were given in the past in Jensen study in the cure unit in California, but at least 5 liters are recommended of polyethylene glycol type solutions. In the past, using a nasogastric tube was recommended as well to try and see if there was any bleeding through the tube. And if there was bleeding, it was an upper GI bleed. But we know that 15% of upper GI bleeds can be missed with that, because there can be spasm of the pylorus and the blood may not reflux from the duodenum into the stomach. But still, a number of the patients with lower GI bleed have clinical presentation looking like an upper GI bleed. So is the timing of colonoscopy important? We heard about the upper GI tract. Well, something that we then say is the one moment when the endoscopy shouldn't be done is in the middle of the night when you have to call the endoscopist. But also some studies have shown that it's not good, usually not a good thing, because you have to, you're sleepy, you need to organize all your team, and usually it's better to wait. Same for colonoscopy, of course. So there are these 2 randomized studies and 1 case control study for diverticular bleeding from Jensen, which was published in the New England Journal of Medicine. That one showed that the outcomes were better for patients who had an early colonoscopy, considers that done within 12 hours with hemostasis, and the other group didn't have hemostasis. But the randomized studies doing an early colonoscopy within 8 hours or within 4 days, they showed, and also the other study by Lane done within 12 hours or up to 60 hours, what they found is similar to upper GI tract, that you find more lesions responsible for the bleed, but the outcomes are not clearly different. So the only point is that I was thinking that maybe, I don't know if it's maybe not always the best thing for the patient, which should be our main target and aim, of course, but in teaching units, probably if you do more early endoscopy, the trainees will be able to do more hands-on training on actual lesions with stigma of bleeding. But yes, we don't know that doing it very early is better than waiting. So in the next 7 minutes, I'll show you about some, probably the videos will not run some of them, but that's fine. So we have, similar to the upper GI tract, we have injection methods. We have thermal methods. We have to be very careful with thermal methods and anything we do in the colon, because the wall is thinner than in the stomach, small bowel and colon. And I suppose that all of us have some experiences, negative experiences with the treatment in the colon because of an injury. So we have mechanical methods. We have to be careful with the over-the-scope clips in the colon. If we suck the mucosa, which you should avoid, because if we suck, we may suck some structures around as well. We can use bands. Probably, apart from the hemorrhoids, most people in the audience won't have used bands for lower GI bleeds like diverticular disease, but in Japan, they're quite frequently used. And we can use loops, the same as the loops we use to prevent bleeds in pedunculated polyps. And we have topical agents as well. I had one video about the Purastat, which is the gel we'll be using in the hands-on training tomorrow. Quite impressive case where the bleed stops with the Purastat, but I can show you tomorrow in the stations where we will be doing the hands-on training. So for angiodysplasias, argon plasma coagulation, which is a non-contact method, is very safe and very good. Something we can do to prevent injuries in the colon is to inject saline before applying the APC, for instance. So make the same as for EMR. We make a cushion. We can do the same. It's been even described doing a resection of the angiodysplasia itself, which I have not done, but it's been described just to remove the whole lesion. And usually we use 2 methods. Injection by itself is not enough. We have to add a mechanical method or a thermal method. Clips are very good because they are supposed to be very safe. You shouldn't cause any injury with them. So how do we treat diverticular bleeding? And this is proposed by Japanese authors. Of course, we can go to the bottom of the diverticulum and find the bleeding site. We can do this by using a cup and sucking the diverticulum so that we expose the vessel. We can go directly to the vessel, or we can, which is easier, just it may be difficult to find the bleeding site. We can just suture the bleeding site itself, the diverticulum itself. But we could use bands as well, which are, the good thing of band is that you don't need to be very precise. Also in the upper GI tract, you suck and you put the band. So you can suck a diverticulum as well, which can be, I wouldn't say life-saving, because these patients usually don't die in this episode of bleeding, but it can be quite easy to treat. Only a few perforations have been described. But it seems to be a reliable, easy to apply method. So this is one of a very old case, but in this case, we could see at the bottom of the diverticulum, the bleeding site, which wasn't treated, but we do something you can do is to tattoo the bleeding site in the diverticulum so that the surgeons can identify, or yourselves again later. And as I said, it can be tricky. Using a plastic cap at the end of at the tip of the colonoscope can help in getting a better views. So we can use a tattoo, and in this case, so it's why I like to record everything I do, because you never know when you have a complication or something will happen. So I have both videos. When I had the first video, this was done by a colleague who took their pictures, and we could see there was a rebleed. We hadn't done any treatment on this lesion. So this lesion certainly had a rebleed, and it was treated again with clips. Yes, I won't show you this one because I can't go to the end of the video quickly, but this is the case. This polyp was removed with the EMR and block, and then there was an arterial bleeding, which was treated with Purostat successfully. I can show you tomorrow in the hands-on or later if you want me to show you the case. And it's very important that whenever we see blood coming from the rectum, it doesn't always mean that it's coming from the colon, especially if the patients are hemodynamically unstable. We could think that there's a quick transit in the small bowel. This patient had a gastroscopy, hadn't had hematemesis. There was blood in the stomach, but there was even more bleeding and active bleeding from the distal duodenum. You can guess that it's quite a bad diagnosis. This patient died when they was taken straight to surgery from here. This was an aortoenteric fistula. So we have to, that's why physical examination, clinical history, this patient had a stent placed in the aorta. That's a massive bleed and the patient died, unfortunately. So importantly, we intervene. So I've spoken mainly about endoscopy, but when the patients are unstable, we can do a colonoscopy straight away, and we have to bring the patient for a CT angiogram. And if there are lesions bleeding, then we have to ask our friends, the interventional radiologists, to do a treatment, such as in this case where there was a bleeding from the small bowel. And the CT angiogram is very precise and it's very safe and non-invasive for the detection of 0.3 to 1 milliliter per minute bleeds. Angiography is very, very good technique. It's improved a lot. It's much safer now with many materials that are less invasive. There's still a risk of ischemia. So when the bleeding lesion has been found on the CT, the treatment has to be discussed with the radiologist. But if the patient is unstable, angiographic treatment will be required rather than endoscopic treatment. There's a role for small bowel capsule, which our colleague, Professor Zakaria has explained very, very well, but it can identify lesions that we haven't been able to find in the upper or lower GI tracts. And of course, so we heard the surgeons are doing less, but it's not that they're doing less important work. They are there for the cases who really need them. And we need always to be, this is a important message, is a multidisciplinary treatment. It's not that I am a star endoscopist or you're the star radiologist or star surgeon. We are a team, and the team has to be there together, communicate the case, and do what is best for the patient each time. So I always, when I consult the patients, I tell them, we are not perfect. We'll do the best thing for you. We'll do whatever we feel is best for you. And that includes your surgeons, of course. So this can be life-saving. And also, what Khalid said, we have to be ready to do an intraoperative enteroscopy. Sometimes the patients are bleeding. We don't know where it's coming from. Then let's open an enterotomy and let's pass the scope, and it will be a teamwork to save the patient. So finally, so just because we reviewed what can be done for lower GI bleeding. So this is a result of the audit from the UK. So 1 in 4 patients with acute lower GI bleeding needed a transfusion. Almost 30% had endoscopy, which is not too much. In the UK, sigmoidoscopy is very much appreciated, and many of these patients had, in fact, only a sigmoidoscopy, which is easier to deliver, of course. Only 2% had endoscopic hemostasis. Many of them had a CT of the abdomen and 6% CT angiogram, 2% interventional radiology, only 0.8%, I think it was, had actual treatment. Scintigraphy is almost not done, but it can be very, very helpful. Half of the patients didn't have any investigation in hospital. So the British are very pragmatic, which is very good, I think, in some cases at least. So those patients with Oakland less than 8 can be discharged safely. And a few of them needed a surgery by transanal or abdominal route. So that's all, sir. In summary, when to intervene, I think we can go to the guidelines. Patient is stable, can have a colonoscopy. It can be done as an outpatient or inpatient if they have a score and the common sense telling us that we have to keep the patient in hospital. If the patient is unstable, they need to have radiology, and depending on the findings, angiographic treatment or endoscopic treatment. Thank you very much.
Thank you. We're opening up for questions. I've got a comment and a question. After that, my co-chair people would ask the questions. The comment is, from the data you showed us, the most common causes you have mentioned is diverticular bleed followed by ischemia. In at least my experience, diverticular bleed is not that common in our country, like you showed in China. And as well as ischemic colitis, we do see, but not that common like the vascular malformations or the hemorrhoids or even polyps and malignancies. The question I have is, suppose you have an unstable patient. From the algorithm, you go on to a CT angiography, because unlike an upper GI, we need to clean the colon before we look at it. And if on CT angio, you see some contrast leak, the two options, I guess, one is to go for a catheter-based angiographic embolization, or even a colonoscopy to tackle the bleed. Which would be your preference, and how would you determine what to do?
Again, I think it's a very good question. And also, I was trying to find some series from India about the epidemiology. I couldn't find in this, but of course, I'm sure there are many that I missed. But I guess that the epidemiology was similar, maybe to China, and probably different diet. But it's interesting to know that particular bleeding is not so frequent. Hemorrhoids as well, of course, are a frequent cause. So it's and what guidelines also say depends on the clinical judgment and on the availability and expertise of the teams. For instance, Professor Jensen in the Cure Center in California, they did was years ago, but they did mainly everything by endoscopy, preparing the patients as long as they were stable, because they put a NG tube, giving of a bowel preparation. There's even, it's not been published. It was presented in abstract form in DW. I think it was preparing the patients with doing gastroscopy, rule out upper GI bleeds, and giving the bowel preparation through the gastroscope at a very high speed. So it was only published as an abstract form. So it depends on availability. But usually, if the patients are unstable, we don't know how long it will take for us to be able to prepare the colon. And therefore, usually, if you have a good team of interventional radiologists, I think we go usually to interventional radiology, considering the slightly increased risk of complications, but depending only on also on the findings. If they couldn't find a clear side of bleeding, then we would need to wait and repeat or go for the colonoscopy. But usually, I think in our experience is interventional radiology if the patient is unstable. Would it be the same here in if there's availability? But if not, of course, you will have to consider keeping the patient stable, maybe in the ITU, giving a bowel preparation with NG tube, and doing a colonoscopy if they found of course, there's always we talked about surgery. Subtotal hemicolectomy has been used for patients with diverticular disease, limited to the left side, with good results, but with high mortality. But good results in terms of control of bleeding. So surgery should be an option if there is no availability for interventional radiology, and surgeons can work. Okay.
Thank you, Professor, for the wonderful presentation. I have one basic fundamental doubt, actually. Please correct me if I'm wrong. Generally, when patients, this is regarding the terminology what we are using, upper GI, lower GI, and small bowel bleed. For an academician, we should know these differences and the incidence and how to manage it. For the practicing clinicians, there was someone who comes with hematochezia. You may not know whether it's patients, most often, it may be coming from an upper GI, small bowel, or colon. So why we need to put the guidelines as lower GI bleed so that our mind is blocked that it is from anything from the colon or from just below the ligament of Treats. Why do we need to the difference? Why can't be just simple as GI bleed, upper GI and non-GI, non-upper GI?
Yeah, but so want to know about how to classify a patient who comes with GI bleed, tell if it's upper or lower, just based on the clinical grounds of what the patients come with.
Obviously, when patient comes with an hematomysis, we know that's upper GI source. But someone who comes with an hematochezia, so we label them as acute lower GI bleed. But most of the algorithms are including from upper GI. We want to look at the small bowel and lower GI. So what do you need to that lower GI and small bowel?
Yeah, so it varies in some of the studies, but the British study, for instance, they included patients with hematochezia or maroon stools or melena with no hematemesis, which can be controversial because a high percentage of patients with melena have upper GI bleed, but without hematemesis. If there's hematemesis, of course, they're considered as a upper GI bleed. But as we said, patients with upper GI bleed with a quick transit, small bowel transit, may have a bleed from the upper GI tract. And in fact, it's 15% of the cases who come as a supposed lower GI bleed have an upper GI bleed. So so you use the appearance of the stools, your finger. I always tell the students and the young doctors that we still need to use the finger, because I did a lot of digital examination when I was a registrar, and I think there's a tendency to use your finger less. But if you don't use your finger, you may make a mistake. So we also use the creatinine and urea relation, and that's very, very important. And if our clinical judgment plus this blood test, plus what we see in the stool, tell us that the bleed may be coming from upper GI tract. And also, of course, when the patient are hemodynamically unstable, because it's very rare for bright red blood per rectum to come from the upper GI tract if the patient is stable. So in that case, that instability, we see blood or melena, even the patient is stable, then we can do a gastroscopy. So about the mid GI bleed, it's I think it's more academic term than practical. We won't be thinking of that unless there's a patient with already known lesions in the small bowel that has a rebleed. Then we could say this probably coming from there. Otherwise, I don't think it's clinical very relevant for the doctor who's doing the on-call work.
Thank you.
Great lecture, Prof. Venki, colorectal surgeon. So in my practice in the last 10 years, GI bleed from lower GI bleed from divertical is virtually non-existent. So whenever we have that, our interventional radiologists and gastroenterologists have to deal with it. Non-diverticular bleed to deal doing blind colectomy is just such an unsatisfactory operation, and you just don't feel good about after doing them. So in the last 10 years, I've not done one because it just doesn't make any sense. So primarily that entire dealing with that problem is primarily with the interventional radiologists and gastroenterologists, at least in our practice in this part of the world.
Of course, yes. Just mentioned that in the older studies and textbooks, they mentioned the surgery for a blind surgery for diverticular disease, which controlled the bleed, but had poor outcomes in terms of mortality, of course. And nowadays there's so much development of the radiology and endoscopy teams and so many devices that, of course, we should rely on that before asking the surgeon to do blind resection, certainly. Thank you for the comment. Yeah.
Thank you, Professor Adolfo. Thank you for a good lecture.
Thank you.
We'll close the session now.
I think there are some more questions, but we'll take them at the end of section 6, which is just on recorded session. So we'd like to move to the next session, which is the 5th one. I'd like to call upon the chairpersons, Professor B. Sumati, Professor Revati, Dr. Chanduran. Kindly take the sofa in front. I'd like to call upon the panelists, Dr. Ravi, Dr. R. Ravi Kumar, Dr. J.K. Jamil, Dr. Vinod Kumar, Dr. Santosh Anand. And to begin with the presentations, yes. To begin with the presenters, I'd like to call upon Dr. Preeti first.
Good morning. The first case capsule will be from Dr. Preeti, consultant gastroenterologist, Apollo Hospital. And the discussion will be from the panelist, Dr. Ravi, Chennai, Dr. Ravi Kumar, radiologist, Dr. J.K. Jamil, Dr. R. Vinod Kumar, Dr. Santosh Anand, and Dr. Karthik Nadarajan. Over to Dr. Preeti.
Thank you, ma'am. The next 1 hour will be a discussion on gastrointestinal bleed. It's an amalgam of cases, and 3 of us will be presenting in continuum. We have tried to unofficially divide it as endotherapy or medical management, followed by failed endotherapy and interventional radiology or other management, followed by surgical therapy if all fails. So I will be talking about 2-3 scenarios where cases have been medically managed. These are our panelists. Welcome. Let's start with case 1. This is a gentleman who came to the emergency mainly with intractable hiccups. His main worry was the hiccups that refused to stop, and he wanted relief from the same. He did not have any anginal symptoms. There was no prior history of angina or any chest complaints. He was diabetic. Hemodynamically stable at admission. ECG showing an acute inferior wall myocardial infarction with a strongly positive troponin. His main worry was hiccups. So he said, before I do anything for my cardiac disease, I want an endoscopy. So we had to talk sense to him. He was taken up for emergency angio. Had triple vessel disease, underwent much against his will, a CABG. He came to us exactly 2 weeks post CABG with significant hematemesis, melena, and presyncope, with a hemoglobin drop from 13.8 to 8. He was resuscitated immediately at arrival in emergency, and an upper GI endoscopy was performed. This is just a slide in brief, talking about the broad etiologies of upper GI bleed. All the ones in the beginning are non-variceal. We don't forget portal hypertensive or variceal bleeds as an important cause of upper GI bleed. Now, Dr. Karthik, let us assume this was upper GI bleed because his main complaint was hematemesis. What is the role of pharmacotherapy and stabilization of the patient prior endoscopy?
Thank you for the question, ma'am. So for almost all non-variceal bleeds, we do give IV pantoprazole, either as an infusion with a bolus dose of 80 milligrams followed by 8 milligram per hour of an infusion of pantoprazole. But the evidence against this is that it only clears the endoscopic field of vision. There's no it does not help on the 30-day mortality. So even IV pantoprazole twice a day at 40 milligrams has been tried. And it has been debated that it can be avoided also. But for all variceal bleeds, this was for non-variceal bleed, and for variceal bleed, definitely, if the individual has no contraindications, terlipressin would be the drug of choice. Since especially in the Indian subcontinent, it's available and it is being used. And if it cannot be used because of any an advanced age or because of any comorbidities like a coronary artery disease, we prefer to give octreotide with a bolus of 50 micrograms followed by 50 micrograms per hour, along with antibiotic prophylaxis in these patients.
Absolutely. So while PPI infusion benefits stand doubtful, they do no harm. So as a protocol, PPI infusion is followed in most centers and is found to be useful, if not harmful, in non-variceal bleed. And just Dr. Karthik said, absolutely terlipressin and antibiotic prophylaxis in variceal bleed. Now, coming to this situation, which is very common, Dr. Vinod, a lot of our patients now are cardiac patients who are either on antiplatelets and or anticoagulants. What is your take on these medications when patients present with GI bleed?
Regarding the antiplatelets, if the patient's on dual antiplatelets, you need not stop aspirin. Monotherapy with aspirin is recommended even if the patient is bleeding actively. But clopilate, the second antiplatelet should be stopped. It depends whether the patient is hemodynamically stable or unstable. If the patient is hemodynamically unstable, you can even continue aspirin if it's a secondary prophylaxis. Whereas for primary prophylaxis, if there is no absolute indication, you can stop for some time and you can restart as soon as possible. This is regarding antiplatelets. Regarding the anticoagulants, if there's an ongoing bleed, it's better to stop and maybe later after an endotherapy, it can be restarted later.
As Dr. Vinod said, antiplatelets to restart as soon as possible. Ecosprin as an ideal antiplatelet agency, especially when hemostasis is confirmed. Second, antiplatelet, depending on the importance of its requirement as a co-administered drug, a cardiology consultation regarding triage or importance of the same to be considered before starting the same. And I agree with his take on anticoagulants. And if bleed is very severe, yes, in cases which are indicated, reversal agents have been used to mitigate bleeding. Sir, when do we scope?
So it depends what time the patient arrives at the hospital. I prefer to do it as soon as possible if I'm in the hospital. If it is in the late night, I wait till next day morning and then do it as soon as I reach. If you don't do it when we were in the hospital, I stay far away from the hospital. Then coming back to the hospital is quite difficult.
I'd request the audience to look at what's highlighted in red. Important is safety concerns when endoscopy is performed. The availability of adequate resuscitation, a robust critical care team, anesthetic team before performing endoscopies. Urgent endoscopies have not found to deliver any added benefit. So this was the gentleman in question. Fresh blood in the esophagus. The stomach and duodenum appeared normal. After adequate washing with the patient, airway protected with an endotracheal tube. An ulcer in the mid-esophagus with an active bleeding vessel was noticed. It was clipped. Hemostasis was achieved. A CT chest was also done, did not reveal any extraesophageal pathology. These are other hemostatic modalities that could be applied to non-variceal bleeds if they are refractory to adrenal injection plus or minus use of hemoclips. Coming to case 2, this is a 53-year-old gentleman who unfortunately fell off a train when he was going back to Kerala after dropping his wife here when she had a transfer to the passport office. This was the history. He came to our emergency with acute left-sided weakness, an immediate CT showing a large temporoparietal infarct and an ECG done at the same time showing an acute anteroseptal myocardial infarction with poor LV function. He was thrombolized. He was planned to be shifted to the ward when he developed melenic stools. Dr. Vinod, what is your take on intensive care of the bleeder? Inpatient who develops a bleed, not someone who necessarily presents to the emergency. Patient who bleeds during hospital stay.
So as we wondered, like a nasogastric tube should be inserted to see the obvious bleed, check hemoglobin every probably 6th hourly or 8th hourly to see whether this bleed is ongoing or not, and register the patient if the patient is hemodynamically unstable. And as soon as possible, start on pharmacotherapy agents like if you are suspecting a non-variceal bleed, start on PPA infusion and do not delay gastroscopy. You can do as soon as possible.
Absolutely. So triaging the patient with respect to quantum of bleed, the utility of a nasogastric tube, the use of prokinetic agents useful before performing an upper GI. And in the event of hemodynamic compromise or massive hematochezia, radiological approach possibly is a better first approach prior endoscopy. So this was the endoscopic findings. There were small discrete antral ulcers, but none of them looked to have bled recently. There was a large ulcer in the duodenum. It was more than 3 centimeters involving the posterior inferior wall and another one as well on the anterior wall. There was a large clot that could not be dislodged in spite of washing. However, there was no altered blood or bleeding during the time of endoscopy. There was bile beyond the duodenal bulb. So it was decided to wait and watch and manage conservatively. Now, this is the utility of the Forest classification to decide patient outcomes at the time of GI bleed. All of us are familiar with this. Nevertheless, it is useful to look at it again for us to decide how your patient might respond to intervention or conservative management. This is just a repetition, but however, a useful one at that. So this patient was managed conservatively. Stools became yellow. Hemoglobin was stabilized. He was shifted to the ward and planned discharge when he developed large melanic stools with hypotension, shifted back to the MDCCU. He was stabilized quickly, underwent an emergency CT with angiography, did not show any active extravasation at the time of CT, but there was an area of spasm in the region of the GDA. Selective angiography showed a blush in the region of the GDA and the superior pancreatic duodenal artery. Selective angioembolization was done. He did not bleed further. Hemoglobin stabilized. He was discharged about 5 days post this. So just to illustrate 2 different cases where at one point endoscopic therapy did help.
You had already seen and done an endoscopy. Patient had shown an ulcer and you haven't tried an endotherapy. So again, patient had a rebleeding. You could have done an endoscopy and attempted a...
Sir, the size of, I will tell you why I personally did not choose to do an endotherapy again. The size of the ulcer, the lack of visibility there with a huge adherent clot, I felt that it was, first of all, it was not possible to wash it off in spite of repeated trial. Second is, I wanted to be very sure whether this is according to guidelines or not is different, but I wanted to be sure that he could be confidently restarted on antiplatelets. He has 2 pathologies. I felt a definitive treatment in the form of interventional radiology would be a safer bet, which is why I directly shifted him to CT, and he was hemodynamically unstable. So I did not want to scope him again. And 5 days. 5 days.
And during those 5 days, we didn't start any antiplatelets.
Antiplatelets were not.
Because
Antiplatelets were not restarted for the first 2 days, after which the cardiologist was insistent that we needed to start, and I had no reason to hold beyond 48 hours because there was no drop in hemoglobin and the stool color had normalized. So we restarted on ecosprin.
Because I agree with you, because you followed the guidelines in the first scope, but I agree with our colleague as well that I wouldn't have left that untreated. That the guidelines would tell you, yes, you can, because you can't wash the clot and it's like a suboptimal view and all of that. But we really have to find a way around, because these ulcer, the 3 centimeter ulcer you showed, I would not leave the endoscopy room without doing something about it, regardless of any guidelines.
I'd like your inputs on the same then, sir.
Sorry?
I would like your inputs on the same.
Yeah, so I would have tried injection. I would have tried clipping and failed, but then I would have at least tried to clip it with multiple clips, because it looks very angry. It looks very angry and dangerous. That's my opinion.
Anyway, the same clot which you saw 5 days back won't be there now.
Agree. The only difference was he was hemodynamically compromised the second time around. That was the main deciding factor, not the fact that he rebled again.
Would you mind if I think this is where the discussion earlier was to remove the clot, see what is underneath and treat it before you come out, was because it's invariable, irrespective of whatever PPI, intensive PPI therapy we give, it is sometimes inevitable that these will bleed because it's a GDA bleed, which you later on identified. It may not have been the salvage therapy, but considering doing something at that point of time would have actually given you more solid evidence to go in and do further therapy, even if it is with interventional radiologist.
When you try to remove such a clot, the person who is trying to remove the clot should have the capability and facility to handle if acute bleeding is incited during the process.
The clot could not be dislodged. That was the point, sir. If it had been, I mean, that's a different story, but I'm happy for the inputs that
Yeah, I think from the picture, it does, I think I missed the picture, but from the picture I saw, I can see that the clot can be removed so easily. So some clots are, of course, you can snare and remove, but some are very tightly attached, and maybe you are going to cause more harm. That,
yes.
I mean, we like to be aggressive if that helps in interventional endoscopies, but some clots just probably it's better to leave them there if they are not easily removed. The other thing is that if there is availability for hemospray, that's a good option, I think, because you don't need to be precise. You just apply it on the...
Yeah, we do not have that facility with us other than clips. Yeah. If you're running out of time, I think I will stop with these two cases. Fine. Okay.
So what's the rationale of giving PPI in direct and indirectly inducing anticoagulant? The mechanism of anticoagulants are not due to aspirin or due to ulcer. It is more of a ischemia. What is the role of transaminic acid, fibrinolytic agents, and misoprostol in this situation? Do you expect the large amounts pumping of PA will stop the GI bleed? We assume so. It's not directly to the ischemic agent. Though it is an acid suppressor, it's more of other agents may be useful in this scenario of post-myocardial status. Patient may be a long duration of coagulation. It's the role of misoprostol. So rarely used. Also to bear it in mind.
A lot of discussion, so carry on.
No role for tranexamic acid and other agents in GI bleed. We'll discuss that later. Just a small capsule regarding lower GI bleed, since this is GI bleed in toto. This was an 82-year-old gentleman, again status post angioplasty on DOACs, brought with significant melena, doubtful hematemesis, syncope, and a scalp injury following syncope, hypotensive at arrival, maroon stools. So the utility of rectal examination, showing bright maroon stools on rectal examination. In broad, the etiologies of lower GI bleed. Dr. Karthik, how would you triage a gentleman or a patient who presents with lower GI bleed?
So basically, ma'am, all the patients with lower GI bleed, we like was previously discussed, we have to confirm based on the history as well as a thorough examination, which has to be rather quick, to ascertain whether it's truly a lower GI bleed or melena with a rapid transit. So to actually to go through it quickly, it would be the age of the patient, especially somebody who is above 60 years of age. Assess whether there are comorbidities in the history. Look for any associated drugs or medication like antiplatelets. Check the pulse if there's any associated tachycardia or hypotension or orthostatic hypotension, history of syncope. And at the same time, we would like to look for any antiplatelets and anticoagulants as well, which can be stopped. If possible, an Oakland score can be done, which helps in ascertaining whether the role of any other therapies or ICU stay will be there, and whether the patient can be discharged with good certainty.
So in summary, how stable is the patient? Is this truly lower GI bleed? Is there an upper GI which is required prior deciding that this is from the small bowel or from the lower GI per se? And the presence of comorbid conditions which dictate patient outcomes at the end of the bleeding episode. I'm sorry, this might be a little repetitive because our previous speaker has spoken very similar. So maybe we should run through this. And as spoken very clearly by our previous speaker, endoscopy, its timing, its preparation was all discussed in detail. Sir, what is your take on the utility of endotherapy in established lower GI bleed? Dr. Ravi.
So it's quite effective in the lower GI bleeding. If diverticulum, as told by the previous speaker, you can manage it through endoclip and sometimes ileal bleeding, cecal bleeding, or some of the early malformation can be managed adequately with APC, various whatever technology we have can be managed. Very rarely you require, if there is a primary disease like malignancy, anyway it requires a surgery, those patients can be taken off surgery.
So the use of endotherapy, use of APC in cases where there is good visualization of the lumen and adequate resuscitation resources are present, can be an effective primary and definitive therapy for lower GI bleed. This gentleman underwent an upper GI, which was normal, and on request by family, shifted for a CCT abdomen, showing active extravasation of blood in the cecum, but more importantly, very bad diverticular disease involving the entire colon, starting from the sigmoid right up to the ascending colon. Underwent a selective angiography, embolization of the branch of ileocolic artery. This gentleman, just to finish off, bled twice more. He refused to colonoscopy every time. And the final time when we did a colonoscopy, I was not able to go beyond the transverse colon. There was very bad diverticular disease and a lot of redundancy of the colon came out at that time. Finally, since he failed endotherapy, interventional radiology therapy twice, he underwent, in a rare case and a rare instance, a subtotal colectomy. I'll stop with this. Thank you very much.
Thank you, Preeti. Actually, it is a very nice clinical case discussion. I would like to know, is it just complete without the adding of your anti-HPA therapy? Because we always know stabilization and different ways of endotherapy, pharmacotherapy. So as a protocol in India, we always have anti-HPA therapy as a part of the bleed, GA bleed. So I do not know, because the British Society of Gastroenterology, what's the protocol they follow in their society? Is it anti-HPA therapy?
Yeah, if it is an ulcer bleeding, then anti-H. pylori treatment is a must. It has to be given sometime.
Thank you, sir. I invite Dr. Seshadri to give his next discussion on the case capsule.
Good afternoon. So I take up from Dr. Preeti. Dr. Preeti has effectively managed the bleeds. And now we'll go to cases where it's going to be otherwise. So let's start off. We are going to have very short cases, very fast. The bleeds are going to be fast. We require fast management of bleeds, very adequate, quick thinking.
But can you manage it so fast?
Let's try. We have 20 minutes to manage, we'll manage. So we're going to chase the bleeds with some of the efficient people here.
We will come behind you.
Yeah. Dr. Ravi will have the last laugh in most of the cases, I think. So the first case, first blood, I think some familiarity for the people from the West. And so This was a busy day at endoscopy way back in April 2017. I've taken exactly the time cases when I dealt at the exact dates. So it was a 59-year-old female diabetic and hypertensive. She's been on NSAIDs for long duration for joint pains, prednisolone, and native medications for joint pains. And she came to the ER with multiple episodes of large volume hematemesis and medina for a day's duration. At ER, she was very hypotensive, tachycardic, and pale. And of course, the usual resuscitatory methods are started, 2 lines, volume replacement, PRBCs. And because she's been on NSAIDs, PPI infusion was started by the ER team. Large volume hematemesis, ET intubation to protect the airway. So took her immediately for the endoscopy. It was a horror there. The fundus was full of blood. I don't have the endoscopy picture, so I have only this picture. So, but that was my expression at that time. It was full of blood, deep ulcer, washed how much ever you do. I could just see a huge spurting vessel and nothing else. So, Dr. Karthik, a young gun here, what are you going to do? Quick answer.
I would try endoscopic modality of at least dual therapy over an endoscopy, dual modality of trying to arrest the bleed. So I would try a mechanical hemostasis in the form of a clip as well as injection here.
Right. So that was fast enough. So I injected at the place. Yeah.
No, see, it is better to delay, prepare the stomach before endoscopy.
Okay.
Sometimes we rarely end up like that, but there are some points for doing even when the stomach is filled with blood. Fundus usually cannot be seen in upper GI endoscopy when there is so much blood. But most of the bleeding, which happens in stomach, they are in the lesser curvature, which still, if there is a lot of blood, you can still see the lesser curvature. And esophagus can be seen in endoscopy. And antrum and D1 are gravitationally anti-dependent. So even when there is so much of blood in stomach, you can still see the antrum and duodenum, and at least you can diagnose. Yes. Fundus, if you need to see when there is a lot of blood, you really need to make the patient sit up. Then only you can see the fundus. Okay. Those are all the pros of doing an endoscopy when there is so much of blood, but still you can arrive at a reasonable diagnosis. And lesions which happen in large greater curvature, usually dolophis ulcers, they don't cause generally massive bleeding.
Yes, sir. So, well taken, sir. Those points well taken. But we tried all the possible maneuvers. Still, what we saw was that spurted.
You made the patient sit up.
Yeah, propped up. Yeah. Of course, anesthetists were there. So we saw the size of the bleeder and we are convinced that it's not going to be of much help. We've actually applied 2 clips. So, Karthik, what now?
I would
I've given you choices there. This is like NEET exam.
I would ask for an urgent CT angiogram and call for the interventional radiologist at the same time.
Okay, fine. So what I did was, there was no time to wait. She was spurting actively there. I know where the bleeding is happening. It's not on site. So I directly called the intervention radiologist and took for direct emergency angioembolization. At embolization, I think Dr. Ravi Kumar was there. There was a major extravasating artery from the splenic artery. He said that the guide wire actually entered the stomach. It was such a huge vessel and with a huge rent in that, the guide wire entered the stomach. And he used glue to embolize the vessel as it was too large for the coils. And there were additional bleeding points which are also embolized. Post-embolization, there was no extravasation. We can see in the pictures there. So at least we got control of the bleeder with that. So Dr. Ravi Kumar, how do you decide whether to glue or coil into the vessels?
See, we use various embolization materials, like we use PVA particles, glue, coil, and all that. Sometimes we use a combination of both coil. In this case, we had used combination of both coil as well as glue. Glue is an acute bleeding which is happening and we have to take care of immediate control. Then if you're not able to reach the blood, reach the catheter up to the tip of the blood vessel where it's bleeding, then you do a flow directed glue embolization, because flow dynamics helps us out to reach the point of bleed much more faster, get control of it at the earliest. And in this case, we had a combination of both glue and coils. Yeah. Okay.
Sheshadri,
yes.
See, this is a splenic artery aneurysm, but most of the other time, if it's a fundal bleeding, it's usually the fundal varix. So in the current day where we use EUS for controlling varicose injection, EUS is one technology which can be done when even when there is so much of blood, even when there is an active bleeding, you can still do some endotherapy.
Okay, right. I wasn't good in EUS at that time. So the patient was managed in CCU with PRBCs. She required antibiotics, unusually for ulcer bleed, because she was on steroids for a long time. She had features of sepsis. Then she was weaned off the ventilator. She did well after that, but a CT abdomen done later showed splenic infarction and some necrosis in the pancreatic tail. Dr. Santosh Anand, will you intervene at this point for this, or will just sit on it and wait?
So just so like to know why CT was done. Was there a specific indication for CT? Like she threw fever spikes or something?
No. At that initially she was not doing well because she was having features of sepsis and all. So we wanted to see if there's any collection somewhere. And then we did it.
Sir, acute splenic infarction without any infection or a pancreatic tail infarction without a necrosis or collection doesn't warrant a surgery that time. We'll just wait and watch only. But if the fever spikes are not settling, showing features of sepsis, if all other areas of sepsis are ruled out, then probably we may consider for intervening.
Right. So we wait and watch. So she was discharged well, and later 1 month later she came for gastroscopy, and it showed a heel fundal ulcer with glue cast and a clip along with it. So the learning point in this is we have to recognize when endotherapy may not be successful, and we have to go for the next modality of therapy and aggressively manage the patient if we feel that we have not done adequate work. So we'll go to the second case. So 77-year-old male patient, this was December 2018, diabetic and hypertensive, post PTCA 5 years. He had melena 2 days, and he was managed with PRBCs elsewhere. He developed chest pain following that, and he was admitted under cardiologist because he was TROP positive. At ER, they found hemoglobin was 6.1 and 3 PRBCs were given. Hemoglobin improved, the chest pain settled, and then I was called for in the late evening for further management. So I did a gastroscopy, showed dural bulb erosions, no blood in the lumen, no ulcers, nothing. Unprepared colonoscopy I attempted. There was only altered blood. I could not see anything. So I told them we don't see a source, so we'll have to relook after preparation, but the patient was unwilling for a repeat colonoscopy. The next day, promptly, he had hematochezia. Dr. Vinod, what did you do? Convince for a colonoscopy now or a CECT?
First, I'd like to convince the patient for a colonoscopy. Since you said the patient was unwilling, and CECT will not be a bad option with an angiogram. Abdominal angiogram will not be a bad option.
Perfect. So I thought as you...
Especially if patient is unstable during the period of hematochezia, it still can be an apogee bleeding. It is worth, since you find the lesion in duodenum, it's worth having a relook.
So that's why I went
apogee endoscopy.
It was very small erosions, which didn't look like the source of the bleed. So I decided to go for a CECT abdomen with mesenteric angiography. Sir. So at CT, there was active contrast extravasation into the proximal jejunal loop on the right side. It was suggestive of a bleed from the jejunal branch of SMA. And there was some splenic infarcts also. So Dr. Vinod, what next? Call surgeon, call interventional radiologist, or try enteroscopy?
And this will be the last thing to do, to call a surgeon. Since we have a active bleed in the jejunal loop, that's true in the proximal jejunal loop, it's better to go with an enteroscopy. The advantage is like you can do an intervention, you can clip it, or you can do a OTSC clipping even with this if we found a lesion. So I'll go with an enteroscopy.
Okay, so you do for a selfie, but I didn't do that. I called interventional radiologist, but I kept the surgeon in the loop. So we explained the need for embolization and possibility of mesenteric ischemia. And at enteroscopy, the jejunal bleed was identified. The selective coil embolization of the bleeding branch was done, and the bleed settled. He was shifted to the wards, and the plan was to start antiplatelets in 2 weeks. So I was happy for some time, but it was not over yet. Promptly in the next few months, the patient came back with severe abdomen pain with bilious vomit. CT was done with the suspicion of ischemic stricture. There was stricture in the jejunum, in the second loop of jejunum. It was again ischemic, as we expected. The surgeon told me, "Didn't I tell you, Machi?" This will happen.
But even even if there is a jejunal bleeding, if the surgeon operates, it's quite difficult to locate the bleeding site during surgery. If a patient had undergone a previous embolization, and even if they develop a
Exactly.
ischemic infarct, surgeon can easily pick up the site of bleeding and remove it.
That's what I told him. Don't I tell you, Machi? Thank you. So laparoscopy was done, and there was a general stricture with diverticulosis at 20 centimeters from the DJ flexure. The stricture resection and primary anastomosis was done. Histopathology showed jejunal diverticulae with focal ulceration and submucosal and subserosal fibrosis ischemic. So likely there was a jejunal diverticulum with a bleeder inside, which was bleeding at that point of time. So Dr. Ravi Kumar, small bowel ischemia with angioembolization, how frequently do you encounter?
I mean, now it's quite common with, the advances of endoscopic technology and things. The number of patients who come to us for intervention itself roughly is around 20 to 25%. The rest of things are beautifully managed by gastroenterologists.
Thank you.
So, but the ischemia, when you say roughly comes between 20 to 15% of the people in small bowel, the more vasa recta that we involve during embolization. So keep it as low as to 1 or 2 vasa rectas. Anything goes above 2 that we have to embolize there. These are the patients who can go in for, what you call strictures or ischemia.
So you told the ways to prevent also.
Maybe it is more, this numbers only indicate those patients who become symptomatic because of ischemia.
Okay.
Otherwise, maybe it is more, but it's symptomatic ischemia is quite less common nowadays. They have
because of
become
better
big
techniques.
experts.
Yeah, technology is advanced now from our side.
Yeah, the catheters, the micro catheters, and those things have improved.
So Dr. Jamil, would you have intervened directly, or you would have sent to the IR if it had come to you?
I think I would have done what you had done.
Okay.
I would have done the CT angio as you did.
Right.
The reason being, this is an elderly man. He's a diabetic, hypertensive. He's had PTCA and he's on dual antiplatelet, right? So you want to do something non-operative first to see if the bleeding can be stopped. And the other advantage is if he rebleeds and if I have to take him to theater, the marker that Ravi Kumar has left in there will help me to identify where exactly the spot of bleeding is. He's developed a stricture 4 months after the procedure, right? Yeah. And it was a diverticular segment. Right. Now that makes me wonder, it's very rare to have small bowel strictures because they do super selective embolization. So could it be that the small bowel was already a disease segment with diverticular and it had bled, and now it's just gone a bit worse after the embolization? It may not have been an entirely normal small bowel which got strictured away completely. So either way, it needed to come out. So the resection and anastomosis 4 months later was the right thing to do.
Right.
But then the idea of doing a selective angioembolization was a better idea than an emergency laparotomy.
Right. Okay. So the points in this is angioembolization is right saving. Small bowel embolization is ischemic strictures should be kept in mind, and we have to have a low index of suspicion when the patient comes back. So we'll go to the third case. This was May 2016, 64-year-old diabetic, CKD on hemodialysis. He's been on NSAIDs for back pain. He had melena for 2 days, admitted to CCU because he had a cardiac arrest during dialysis. His hemoglobin was 3.3. He was transfused under the cover of dialysis. PPI infusion started. Again, it was called for gastroscopy. Multiple duodenal ulcers, one with an erythematous surround, but there was no visible vessel. It was porous class 3 ulcer. But since I was erythema and since he had bled significantly, I thought I should do some endotherapy and come. So I injected around the base and it came out. He says it settled subsequently. Day 3 after I did a recheck gastroscopy, clean vase ulcers, no bleed. Colonoscopy I did at the same time because the amount of blood he had bled was out of proportion to what we saw. It was shown only diverticular. He was discharged. But 1 week later, he promptly came back with melena with hemoglobin 5.6. So Karthik, relook gastroscopy or angiography? Fast.
If he's hemodynamically stable, we'll go for a relook gastroscopy again.
Right. So I did an CT angiography.
Seshadri, patient was a renal failure patient.
Yeah,
he was on dialysis. His hemoglobin would have been 7, 6, even otherwise.
There was a significant drop.
So
and,
2 milligram, 2 gram per cent. Initial hemoglobin on of patients who are on dialysis, CRF, it will be around 7, 8 only.
No, but there was a significant drop. That's why we went in. So there was a bleed from the branch of pancreaticoduodenal artery. And again, as Dr. Preeti discussed the last time, actual extravasation could not be seen, but there was a spasm at the level of the site of the bleeder. So coil embolization was done at the point of the spasm, and then he subsequently stabilized. So Dr. Ravi Kumar, what are the subtle clues when the extravasation is not seen? Any role for provocation?
Yeah. See, this is on CT angio. Now, the CT angio is the best modality to pick up any arterial GI bleeds. If the CT angio does not show an active extravasation or obscure signs of CT angiogram for GI bleed, has to be looked into. So you need to study the CT angio very quite well, intensively, in the sense when you look at a CT angio and say that there's a frank bleeding, it happens only in 30% of the people. That doesn't mean that he's not bleeding. What are the obscure signs that we need to see? One is the vessel can be in spasm. So you need to see whether the vessel is in spasm, distal vessel. Number 2, this is all on CT angio, not on invasive angiogram. Before we take them up for invasive angiogram, I look into all this. Then we look into sudden increase in size of the vessel. The vessel usually goes on tapering distally. If suddenly there is one portion of the vessel which is suddenly increasing in size, that is again a warning sign. Number 3, you see for submucosal lesions like deulophobes, and you look for any arteriovenous malformation. And you also need to look into the early portal venous phase size, where you look for any increase in contrast at these points. So these are the subtle signs that we need to see. Once you see this, then you're good enough to take the patient for endovascular intervention. Right.
But Seshadri, if you had seen a lesion in endoscopy, that is good enough reason to presume that that is a cause of bleeding. Provocations are required if you don't see any lesions in endoscopy and you're suspecting something in small bowel. Those are the cases where you use provocation to induce bleeding during angiography to locate the site of bleeding.
Right. So we'll quickly go to the bleed 4. I think this will be the last case. I'll cut short one case. So this is June 2018, diabetic 64-year-old male, massive hematemesis 2 days prior to coming here. He had a gastroscopy elsewhere. Esophageal varices, EVL was done. Came to ER, drowsy, hypotensive, tachycardic, resuscitated and started on PRBCs, IV terlipressin, because he was known to have varices. So
the hemoglobin is 4. Anyway, if you have waited some more time, as the speaker, one of the speakers said, it would have stopped anyway.
But he was bleeding massively, sir. So I went for a CT abdomen. The CT abdomen.
It is not the bleeding actually which causes problem in varices. Most of the patients, if you don't manage pressures during bleeding, particularly in variceal bleeding in patients with cirrhosis, subsequently they will, even if they recover that time, even if you obtain a good control of bleeding, many of them will develop liver failure and it will be a downhill course.
Right. So in this patient, he had hematochezia, he had large volume hematemesis also. So I thought there are multiple sites of bleed and I went to the CT abdomen, which of course showed varices all over, top to bottom. So the next move was obvious. I don't let my IR sleep. I called him for an emergency tips. This was in the midnight. And we explained to him the importance of tips, the possibility of hepatic encephalopathy. Opening HVPG was 25. Portal vein calcification was seen. TIPS was deployed across and HVPG reduced to 18. And it was good flow was there. There was the flow into the esophageal and variceal systems was diminished. So quick 2 points, sir, and then we'll, I think we'll shut down.
Yeah. Choosing the stent size in acute bleed, that we got the maximum size is only 10 millimeters. So we deploy 10 millimeters and leave it off. And invariably, if it's actively bleeding, we like to go and block off the left gastric vein and then embolize and some of the splenic vein collaterals, which are there supplying the gastric barracks. And with regard to the question of your experience and tips for bleed, it's quite good. Uncontrolled refractory bleeding with coagulopathy have got the poorest results. But when you're doing preemptive tips, the results are quite good enough for as far as the patients are concerned.
Dr. Ravi, any takes it?
I don't know. I've never referred a patient for tips for GI bleeding as
Okay,
such.
fine.
But if they have other indications like severe ascites when they have a bleeding and then you need to control. Because tips also has as problem, and it should be seen as a pre-procedure in patients who are subsequently undergo transplant.
Right. So this patient went on well in that admission. Repeat Doppler showed a good flow. But of course, he developed multiple episodes of encephalopathy. He was not willing for transplantation and he expired later. So the learning points is, remember tips when you think of multiple sites of bleed and also bleed. Of course, consider the possibility of hepatic encephalopathy. Explain to the patient. I will skip this case. It was a ileocecal ulcer bleed. My Pongal day was demolished that day. So the lesson learned is like one would like to be a hero as an endoscopist, but we should remember that the final success involves a team effort like what we had at Chandrayaan. So I know it's. So thank you. Over to Prema.
Thank you, Dr. Seshadri. That was
There is a comment which need to be give a mic to him. Experts are sitting there, Basmani, and we are all sitting here and talking.
Yes, thank you.
From the panel.
First, I'd like to say I'm very jealous of your relationship with your interventional radiologist. I have never seen this anywhere. Okay, like we can't get a CT out of ours. Mind you, an interventional radiologist that fast. So you must have a very special relationship.
Exactly.
But you must have funding as well. So that's the case number 2 is I'm still very curious about. So you have all these facilities. That fundal ulcer, if you had an Ovesco clip,
the first one.
No, number 2, the bleed number 2 from the fundus.
Yeah.
If you had an Ovesco clip, would you have used it, or you didn't have an Ovesco clip? That's why you went to the radiology.
It was 2018. I don't think we had the Ovesco clip at that time.
Okay, but if you had it, you would have used it.
Yeah.
It's quite difficult, in the fundus.
It's a little difficult.
It is difficult, but it's easier than taking the scope out and calling the interventional radiologist. And I'm just asking because we do a lot of Ovesco clips after bariatric surgery for leaks and tears. So if you had an Ovesco clip at that time, would that be your inclination, or would you still go to the radiologist?
I would have gone to the interventional radiologist because one thing is I was just in as a consultant at that time. So I wasn't too confident, first thing. Second thing is it was a huge vessel, which we thought whatever we do, we are going to not get good control over it. Third thing is, even if Ovesco was there, I think the technicality is a little difficult. That's what.
Okay.
You said you joined as a new consultant there, but there are more senior people there in your department.
Yeah, that's right.
You can always call them.
I always call for help. In fact, in this case, Dr. Oval was there. So we decided together that we call the interventional radiologist and
I think. Okay, we'll come to the last part of our panel discussion. I think to follow Seshadri is always tough. He has all those nice videos to come up through with. So I'll start off with much more mundane stuff. But here, I have 2 case scenarios where, we have been discussing since morning about how to resuscitate and then get the patient up for your endoscopy and things like that. But sometimes in real life, it is not always that easy. And sometimes it could be intermittent where we think the patient is pretty stable, but suddenly they collapse. So here's the first case is a young male, 32 years, had gone to another hospital with a history of melena for about 2 days, no hematemesis, had a syncope, and was noted to have low hemoglobin of 5 grams.
So in a person who has not had any comorbids. So he was transfused about 3 units, tried to resuscitate this hospital. But again, the subsequent hemoglobin, he was continued to have melena. His repeat hemoglobin about 6 to 8 hours later was 6.2 grams. So they thought, well, not to be managed at that center, and they referred here for further management. He has not had any history of fever, no NSAID intake, no history to suggest any liver disorder or any comorbids in the past, and he has not been on any medications. So at the ER, we find that he is quite tachycardic, pale, abdomen is soft, non-tender, no evidence of any liver disease, and hemoglobin at arrival is just 5.6. He has bled further. In the next 12 hours, we try to resuscitate him. He gets about 3 units of packed cells going. Resuscitated reasonably well, and then we did an endoscopy, which looked normal, pristine, unprepared colon. That's, I find, complete lot of altered blood and clots all through. It could enter into the terminal ileum, but again, mucosa is stained with blood. So at this point, I mean, we thought probably, yes, I feel that probably it is something coming from the small bowel. So go ahead, and I got a CT abdomen with angiography. But the report here says it's just hyperdense clot contents in the colon. There's no obvious bowel wall thickening. There are no nodes, and they couldn't see any active extravasation of contrast. So I mean, he has already received about 6 units of blood at this point in time, totally, from the from onset of his illness, from the onset of his bleed. So keep both the good friends, IR and the surgeons, in place. His hemoglobin is only about 6, so he tried to correct it to the 8 or 9. So he receives the 2 units further during the day, and his hemoglobin kind of stabilizes by the next day. So at this point of time, I would like to ask the panelists, each one of them, they can give their opinion. Now he's reasonably stabilized, but we still don't know where he bled from. So what would be the options? First, Dr. Ravi and Dr. Vinod, what would you want to do at this point? He's received about 8 units till now. Right now, his hemoglobin is
if his hemodynamic is stable, I like to repeat a colonoscopy after a complete preparation, sir. If that is normal, I like to go for small bowel endoscopy.
Small bowel endoscopy.
So here we are in a situation where upper GI endoscopy is normal, but he has active bleeding. So there are some conditions where upper GI endoscopy can be normal when there is a bleeding. For example, durafy lesions are very easily missed. And when the hemoglobin is so low, sometimes we can easily miss many of the ulcers, duodenal ulcers. Maybe ulcers are in a difficult place. One important site of bleeding, which I come across very often nowadays, because the place where I work, the pancreaticobiliary causes. Hemophilia and hemosuccus pancreaticus are 2 situations where you won't see anything in upper GI. If you go sufficiently wide in D2, or if you use, you may see some stains of blood in D2. And of course, small bowel is the next source. If you think it is small bowel, and if you think patient is active bleeding, this is the best time to do a capsule endoscopy.
That's what I was about to ask. What would be the choice of the experts here, as well as even from the
Hariharan is there, capsule
or direct enteroscopy? What would be the choice of the thing? Right now, he's kind of stable. Hemoglobin is holding. So what should be done next? Sorry, capsule would help. Okay, but doesn't that, again, the question is the timing. Again, we have all the options available, but sometimes if it is kind of an intermittent bleed, a negative capsule also doesn't. What is the good timing to do a capsule when you have an active bleed?
If there is an active bleeding at that time, that is the best time.
Enteroscopy or capsule? Which
capsule is much easier for patient to accept it. So, and next time after doing an endoscopy, if you don't find, by the time bleeding might stop. And if you do a capsule endoscopy, it's easy to find the site of bleeding in GI bleeding with a capsule rather than the cause of the lesion. Sometimes even if you find a lesion which is not actively bleeding, you can't presume that that is the cause for bleeding. So when there is an active bleeding, that is the best time.
Any other thoughts?
I totally agree with what has been said. One of the things what we did in our unit was just very quickly, ours is a very big GI bleed unit. We looked at the normal OGD, normal colonoscopy, and what happens to the patient next. And in that audit, what we found was repeat upper endoscopy yielded more results than a repeat colonoscopy. Or even the small bowel examination, because the times we miss smaller lesions, smaller in difficult areas like alluded before, it's quite frequent. So up to about 17% of the patients did have a pathology in repeat upper endoscopy.
So your unit will repeat an upper GI?
We do repeat an upper GI endoscopy. If we have a suspicion that there is ongoing melena, raised urea, persistent raised urea, or any tachycardic symptoms, we would repeat upper endoscopy.
Yeah, when it said mentioned urea, if a patient has a raised urea, it's very likely that the source of bleeding is much proximal, except when they are cirrhotic patient where raised urea may not happen.
Okay, I mean, how comfortable are we in giving a colon prep when the patient has had some massive transfusion requirements? Like he's already required 8 units in the last 24 hours. There's a little worry that whether the prep itself can precipitate a bleed. Is that unfounded or is it true? What is your take?
If you simply precipitate bleeding, that is why you should transfuse to the extent of 7-8 grams of present. It also depends on the
colon preparation. I mean, preparing for a colon, bowel prep.
Bowel preparation.
Yeah. So does it induce a bleed or what?
Very unlikely. I don't think so.
Yeah, I don't think there's evidence showing that, but it does show that you will be more likely to find the bleeding site. So it shouldn't cause a bleeding, and the large series having used large volumes up to 12 liters of, they didn't mention on the suspicion of the bleed having been triggered by the bowel preparation. But again, if it eventually happened, you are there with your colonoscope to treat it. So I think it's.
If it induces bleeding, you're lucky. You'll be able to identify the site of bleeding.
No, what happened here? So I'll tell you. Melena continues, but hemoglobin appeared stable overnight. So we thought it was some old blood which was rushing through. We did prepare, but 3 hours later, he had a bout of hematochezia with hypotension, unfortunately. Got him again stabilized, 2 units of PRBCs. So what will be your take now? The surgical IR, or what? When was the surgeon happy?
You need a capsule?
Not it. The plan was to repeat a colon para capsule, but when we gave a bowel prep, he crashed. Let's see.
I mean, his OGD was normal.
OGD was normal.
Colonoscopy showed dark blood. So it's probably a small bowel pathology here that we're dealing with. I mean, as you rightly said, you would have gone for a capsule endoscopy for stable, but he's now unstable. So the options are, I mean, I would go for a CT angio first.
I've done one already.
Right. Well,
I mean, practically that's where, I mean, how do we choose?
Okay. Well, the next option is for me to take him to theater and do an on-table enteroscopy.
Anybody else?
Either laparoscopy and on-table enteroscopy or a laparotomy, depending on how quickly we need to sort the problem out.
It will be quite difficult to locate the bleeding because the whole bowel will be, because of the clots inside, it will be colored. It's very difficult. If they have an active bleeding, if you segregate different segment by clamping, then one segment it may fill up. That way you can look at the locate the bleeding. But the hematochezia and hypotension is a condition where it doesn't tell us it is from the lower GI, middle GI, upper GI. It can be anywhere. If they have a hypotension, the bleeding is massive. Even upper GI can cause hematochezia.
So when do we go for an enteroscope, surgery, repeat upper GI? What now?
Resuscitate them. And if you do a repeat CT scan, particularly when resuscitate, simultaneously do a hypotension. And if you don't find the bleeding, you leave the catheter in the femoral or wherever they have. And then when they rebleed again, you can do a repeat CT scan.
I mean, he's a young man, right?
Yes.
You've already done a CT angio and you haven't found the bleeder. And now he's deteriorating. I think we need to take him to theater. and
So-
you need to come to theater.
With an intraop endoscopy.
Well, yeah,
Okay,
intraoperative.
that's an option.
So that's the option, because what we don't want here is a young man, deteriorating.
We know.
No, you
What's
may
your
not know
thought?
where the source is. If it's clearly because of small bowel source, we could have taken him to theater and probably do an intraoperative endoscopy. What I do is I resist the patient, proceed on with the scopes. Again, do an endoscopy and colonoscopy, followed by a small bowel evaluation.
No,
And
here
if
we are
again
looking at
fails,
this not, I mean, he has already received about 8 units, right? So, I mean,
if
this
he-
kind of.
if he's not fit for an endoscopy, how come he can be fit for an intraoperative endoscopy?
He's a young man. He will
Correct.
tolerate some hypotension.
I
If
understand.
it is an old man, he won't tolerate. You need to do something very urgently.
Yes, sir. So, one. Right, so nuclear bleed, I mean, Meckel scan, you would say.
But we don't have time for that. He's unstable.
He's unstable.
I agree that some intervention is needed. So if the patient had the bowel preparation, has been stabilized, I agree that enteroscopy would be, you want something quick, but I would talk with the surgeons to be there by us, maybe start with an enteroscopy without an enterotomy. And if it doesn't work, then be ready for the enterotomy.
So in the OT, we'll keep him in the OT and do all that.
Yeah.
Okay.
And it's not blind small bowel resection, by the way.
Right.
I mean, when we open or when we do a laparoscopy, we usually have some kind of an idea about where the bleeding has happened.
Right.
With this amount of bleeding, definitely the surgeon should be able to have some idea. If there was a lesion, yes, you will definitely know it. But if there is no lesion, and if there's been some massive bleeding by looking at the mesentery, by looking at the bowel caliber, and the kind of the alteration of the blood, which we can see through the lumen, surgeon should have some idea. Not to suggest that he has to go ahead with the resection with just that guesswork. He has to be guided by the gastroenterologist who will be coming and doing an on-table enteroscopy.
But again, I mean, having done a few of this intraop endoscopy for bleeds, sometimes it's, I mean, I would request the other's opinion also. Sometimes you put in your scope, you find blood everywhere. We don't know where exactly he bled from unless you find a clear-cut ulcer or a good, polypoid lesion, something. Because you find blood moving up and down, and it's very difficult to even locate a scope.
That's where as Dr. Ravi mentioned, that's where the advantage of clamping and milking comes in.
Right.
So the clamping and milking out of the blood from the bowel lumen helps you to identify the lesion better.
Right. So in this patient, I think.
If if there is a lesion in the form of a mass lesion or something located in CT, then when they do a laparoscopy, they will have a finding which can be appreciated. But if you don't have anything in CT, it is very unlikely there will be a clue in laparoscopy to suggest that this is a site of lesion.
But anyway, this gentleman, we took him to the theater. So at that point of time, we didn't have double balloon or enteroscopy or anything. So
that it's a likely small bowel.
the colon had shown some altered blood. Small.
Blood from, if they had swallowed blood from hemoptysis, there will be clots in there.
But I mean,
It doesn't mean anything. Presence of blood in colon doesn't mean anything.
no, in the terminal ileum, that was what it was.
Ter-
Terminal ileum had shown some.
See, even if it from dental bleeding, it will go through the
Fine.
go through the terminal ileum only.
True. So in the intraop findings, sure. Okay. So there was a protuberant vessel seen on the serosal aspect in the jejunum, which the surgeon was able to identify. And the rest of the bowel looked normal. Intraop enteroscopy, there was no active bleed, but lumen, as was expected, was filled with clots. Again, there was no active bleed at that point in time. But he found that there could be something like an abnormal AV malformation kind of this thing. So resection anastomosis was done. Finally, the histopath came out as jejunal delifoy. He did well after that. So I'll rush through this because we don't have probably much time. But as another case where in an elderly gentleman, he has all the comorbids that you can think of. CVA, basilar artery coiling, thalamic infarct. He's on dual antiplatelets. He's had GI bleed in the past. He's already had a jejunal resection and left hemicolectomy for an angiodysplasia. Again, presents with bleed, syncope, and then hypotension or borderline pressures. So again, creat is 1.8, hemoglobin of 4.6, ejection fraction is borderline 45%, resuscitated, hemoglobin continues, doesn't hold good as we expect with 3 units of blood. His hemoglobin is still 6.2, ongoing hematochezia. Is he a candidate for a colon? I didn't think so. So I did a CT abdomen with angiography, multiple diverticular in the small and large bowel. Intraluminal extravasation of contrast is noted in the cecum in the delayed phase. They don't think it's an arterial bleed. They were very categorical that it could be a venous source of ooze in the cecum, could be diverticular. And we had our good friend who said that, no, this is venous ooze, I'm not going to intervene. So a surgical consult was taken. So at this point in time, like these kind of elderly patients with multiple comorbids, he's still on antiplatelets till a day back. How good is an endotherapy going to be?
I will definitely refer it to my friend, Dr. Revati.
Why is that? Anyway, so he was planned for a colonoscopy since we know that it was a venous bleed, but is despite massive transfusions, another 2 units, his hemoglobin continued to drop, and he went on to requiring inotropes. So here is a gentleman where we want to, the guidelines would suggest that we should try and resuscitate and get them better before we scope. But sometimes it doesn't happen, particularly when they are elderly and they are on antiplatelets. So we are left with nothing but to move in again for a surgery. Here we found extensive additions. His old operative surgeon, he's had multiple segmental resections and sigmoid colectomy. I could find, multiple colonic diverticle. I think Anand Santosh could tell us. There are fresh blood and clots noted in the colon and in the terminal ileum as well. So he underwent a subtotal colectomy with ileorectal anastomosis. Subsequently, had a little torrid post-op course, but then he went home subsequently. So in general, generally we see that most often, like the role for surgeons has been discussed, as actually come down with a lot of endoscopic interventions, intervention radiologists. But I think surgery still plays a significant role where we should involve surgeons right up from the beginning. They should be, particularly in patients with major GI bleed, they should be doing the rounds along with us to see what's happening. This is an audit of this is an upper GI bleed. Of course, in India, they found that surgery was required in about 5%. So 95% of the times, possibly we will get away with just endoscopic and interventional this thing. And I think these things coming from UK and acute upper GI bleed probably 10 years back, again, surgery was possibly required in about only 2%, and lower GI bleed again was less than 1%. So, but surgery does play a role. Yes, sir.
Dr. Adolfa mentioned about tattooing diverticulum. What is the reason? Why did you do a tattooing? Is it to help the surgeon or help yourself to identify the place of bleeding?
That was a very old case, maybe 20 years ago or so, I think. But it wasn't because the diverticulum was not treated, and it was tattooed. But even if it had been treated, because it was bleeding, if you tattooed, so the surgeon would locate the area where the diverticulum is. Of course, if they do surgery, they're going to remove the whole segment. But sometimes the diverticular disease is very extensive, and it would be better, even for the endoscopist, in case that they had to retreat. So that's been described in some series of diverticular bleeding.
It is for diverticulum.
Yes.
So, but when we operate for a diverticular bleeding, we don't operate only the diverticulum. We anyway do a segmental resection. So only risk, I thought, in tattooing in colon, sometimes these, you used an India ink?
Well, we use
methylene glue.
In the past, we used just ink, which was commercial, but nowadays we use a spot, which is a sterile solution.
They're changing the India ink to Baran thing from next year.
Yep.
Okay. Are there any other surgical indications?
Sometimes ink, when you use it, if it goes to the peritoneal cavity, then it causes extensive black coloration, and then it will be a misery for surgeons.
Yes. And so when I tell my trainees to tattoo, we inject a saline and then to make a bleb, and then we inject a tattoo, because I said that first the surgeons will see it full of tattoo, and then they will laugh at the endoscopist. So we have to be careful about that.
Yeah. Any other indications that you think?
Just to add on to what Dr. Ravi said, when we do the resection, we're not that specific about where that bleeder was. It's usually a long segment of colon. And the way we decide about the extent of resection is by actual feel. The normal colon feels a lot softer than the diseased colon. And even if the diverticular disease was documented to be only up to, say, proximal, mid-sigmoid at colonoscopy, if there are no diverticulae and if there is still some thickness extending all the way up to proximal descending or splenic flexure, we end up resecting the entire left colon. So it is the surgery for diverticulitis is not just about resecting the segment which caused the problem 6 months earlier, but resection of the entire diseased colon. So it doesn't really matter whether it is inked or not inked.
Okay. Final comments. I think we're almost running out of time.
The other area where surgery will be very satisfying when GE bleed happens is, as Sir said, Meckel's diverticular bleed.
Right.
So that will be a definitive cure for the patients. Usually, CT angio may pick up at particular places. That time also, like we can directly go in for surgery if it is an acute bleed, or sometimes we can stop the bleed with that area, and then we can go in and do a resection anastomosis.
Okay. I mean, finally, what would be, I mean, rarely we do find, sometimes we do all probably even on intraop endoscopy, you don't localize a bleed. Is there a role for a blind so-called right hemicolectomy, or what would be your approach?
So these days, blind colectomies are not practiced. At least we need to locate it by doing an intraoperative endoscopy.
That is also negative. You don't see or localize a lesion, or so what will be a surgical approach? Like we already
we are sure that it is from colon. It's less satisfying surgery, subtotal colectomies, if we are like in all possible ways to rule out rule in this is the particular place of bleed. In that, maybe a subtotal colectomy will cure the disease.
Yeah, so as I agree, as Dr. Santosh said, there is no role for any blind bowel resection in this day and age where there's advancement of endoscopic techniques and angiographic techniques. If as a last resort, if you really don't know where the bleeding is coming from, and if you think it's highly likely to be from the small bowel, and even the enteroscopy has not picked it up, there is something called split ileostomy, which can be done. And what it means is you resect the bowel right in the middle of the small bowel and bring two barrels out, and you see what happens in the postoperative period. It gives you, I mean, it gives you an opportunity to just narrow down on your segment of small bowel, but that's very rarely done. I've seen it just once in my life.
Sure.
Okay. Thank you, Dr. Prima. It was
Thank you.
Too much debatable. We couldn't had a better panel than this. It was a lively discussion. I think at the end, we should be like three musketeers, the endoscopist, surgeon, and the interventional radiologist. Yeah.
Thank you so much for the last session. We'll have the final session now, which is the sixth session, for which I'd like to bring on our chairpersons, Professor Padmanabhan and Dr. Sarojini. I'd request them to kindly take the stage, and I'd request Dr. Mo Tawfiq to introduce our final speaker. He couldn't make it, so it's an online presentation. Professor Colin Rees.
Thank you, guys. It's been a fascinating day already. I've been given the pleasure to introduce Colin Rees. I mean, Colin Rees in England and Europe does not need any introduction, and he was so keen to get introduced here, and he's very keen on the brand India, or as we mentioned, Bharat, probably. So, but he's very keen to collaborate in the future. And I'd like to mention a few words about Colin. Colin Rees is a professor and he's the president-elect of the British Society of Gastroenterology. So he's a consultant based in Newcastle University, and he holds an honorary consultant position at South Tyneside and Sunderland. He has a fantastic and a massive track record of research. He's probably the most published researcher in the field of endoscopy in either the world or perhaps in Europe. He is the chair of a founding chair of the Northern Endoscopy Research Group, which publishes like nobody's business. It publishes papers like newspapers, and they have the largest database of endoscopy in the world. And he's also a happy man nowadays because he's a Newcastle United fan, and Newcastle is doing well. And my son is as a student in Newcastle, so it gives me great pleasure to introduce Professor Colin Rees. Colin, thank you. Over to you. Oh yes, unfortunately, he's a good-looking man. Unfortunately, he forgot to put his picture on the camera.
Thank you to Basu and to colleagues and the President of the Society of Gastroenterology and Professor of Gastroenterology at Newcastle University. And to a little bit this morning about prevention, screening, and early diagnosis of colorectal cancer. I hope this is of interest to colleagues at our hospital. So these are my conflicts of interest. What I want to do is talk a little bit about colorectal cancer in general, talk about how we improve our hospital, talk about prevention, risk factors about chemical testing, and then a little bit about some of the, very briefly, the vision we have for colorectal cancer research. So remember that colorectal cancer is the third commonest cancer in the world, accounting for just under 2 million cases per year. Colorectal cancer is commoner in males and tends to be commoner in Western countries, particularly amongst white populations. When we go to deaths, it's the second commonest cause of cancer death, accounting for just under 1 million deaths per year. Colorectal cancer accounts for around 65,000 cases per year. Talk a little bit about instance of that shortly. This is just how the instance is varies between men and women. Look here, colorectal cancer is the 13th commonest cause of cancer in and the 13th commonest cause of death. And as I said before, there's around 65,000 cases per year. Something that's rather troubling is the rising instance of colorectal cancer in India. If we look at the scheme at the top here, where I'm based, it's stayed fairly steady for the last 50 years. The Indian instance has risen quite markedly over those few decades. And it's very likely that this is due to changing lifestyle, a more sedentary lifestyle, and the increased instance of obesity. So some survival rates, and unfortunately survival rates for colorectal cancer in India are not great, generally less than 30%. So clearly this is a growing problem in India and something that I'm sure that people on this call are becoming aware of, and it's becoming a growing burden. It's of older people, you can disease of people over 60. And in terms of risk factors, around 30% of colorectal cancers have a familial component, but only about 3 to 6% are due to key mutations such as Lynch syndrome and BRCA. Identity loci have now been associated with colorectal cancer risk. And in terms of family history, if you have one first degree relative, again using UK data, your risk is just about doubled. With 2, it's up to about 3 times. And if in young first degree relatives, it's significantly higher. One of the risk factors for colorectal cancer: exposure to radiation, diabetes, hypertension, and other features of the metabolic syndrome. non-steroidals, oral contraceptives, metformin and statins are protective. Red meat, processed meats, alcohol, being obese, being tall, and smoking are increase your risk, and physical activity and high fiber, high oat-based foods reduce your risk. So in the United Kingdom, our estimate is that around 50% of cases of colorectal cancer are preventable through lifestyle factors. Remember of the abnormal carcinoma sequence, which was hypothesized by August many years ago, we really haven't moved on from this, apart from some cases, for example, like colonic microsatellite unstable lesions. But generally, it takes around 10 to 15 years to go from normal epithelium through to colorectal cancer. There are multiple opportunities to intervene. I mentioned this area down here, which is the pre-cancer stage. Pre-adenomatous stage, but then there are potentially opportunities from adenoma to cancer through removal of adenomas and chemo prevention. And we started screening, find about 10% of our cancers, and then we count for age. Colonoscopy is the investigation of choice, but we have many issues in the UK now with our endoscopy services being swamped, and I'm really good at taking the research that we have and translating it into practice. So as a researcher, there are really multiple opportunities to investigate colorectal cancer and to undertake research at lots of different stages. I'm just going to give you a few examples of that now. This is the gold standard for investigation of colorectal cancer. It's imperfectible. This famous paper by Kaminsky et al. In 2010, demonstrating that there's a tenfold variation for adenomas of all sizes and about 3 to 4-fold for, this paper didn't demonstrate that. So we know that there's a tenfold variation and that's 3-fold for adenomas more than 10 millimeters. But what this paper demonstrated is that adenoma detection rate is strongly correlated with instance of post-colonoscopy colorectal cancers. So adenoma detection rate of an endoscopist, if you take myself, if I have a low adenoma detection rate, patients scoped by me are more likely to have missed cancers. So we know that adenoma detection is extremely important. So one of the important things clearly to ask yourself is who actually did your colonoscopy. So this is a study that we undertook in the United Kingdom a few years ago, where we use some of the evidence-based measures for how you improve colonoscopy, slowing withdrawal time, using antispasmodics, in patient position, and flexing in the rectum. And we demonstrated that actually through a simple bundle of measures like this, you can improve quality of colonoscopy. We saw a rise in muscle values from 15 to 53% during this, just a simple bundle of measures. And interestingly, 3 years later, when we came back and looked to see whether this effect had been sustained, as you can see down at the bottom here, this effect had been sustained. So you can get able to improve the quality quite easily if you base it upon evidence. So, what about technology? Now, this is work we've done with the end-of-cuff vision device. I'm going to show you end-of-cuff vision in action here. So here is the plant you can see these blue fronds coming on the left. This is the end-of-cuff vision, which sits on the end of the frond scope. It holds the folds out of the way and improves detection of adenomas. So this is the so I've just managed to repeat that again. I'm going to move on to the next slide. This is the adenoma trial that we undertook, where we showed a 5% increase in adenoma detection with vision in our cancer screening program. So these people who have fecal local blood positivity, we saw an increase of 11%. What we're able to do with a large trial like this is change practice in the United Kingdom. The details of this aren't particularly relevant to you, but one of my passions is for gaining high quality evidence for changes in practice. And I think we should be doing large trials in endoscopy to change practice. This is a study that we have just completed using artificial intelligence, the GI Genius module, which you can see here, which puts a small green box around pipes and helps improve detection, we believe. So we've just completed that trial a few months ago, and we'll have the results for this in the next few weeks. We've submitted them to the European Gastroenterology Week to present in October. So This is a summary of colonoscopy studies that we've done. So, numbers of patients and informing practice. So about chemo prevention, this is the seafood trial led by Mark Hull from Leeds in the United Kingdom and published in the Lancet. And this demonstrated that it was a trial of eicosapentaenoic acid, which is a fish oil and aspirin, and it shows that EPA reduced conventional left-sided adenomas, and aspirin reduced the instance of serrated lesions, particularly right-sided lesion. So this is important. It's not the end of the story, but it's important for the signals to the benefits of chemo prevention. And ColoPrevent is a trial which Karen Brown is leading from Leicester in the United Kingdom, looking at aspirin as standard of care versus metformin or resveratrol. So about risk factors for colorectal cancer, this is our cohort study. I think it has three aims. Firstly, to develop a risk stratification tool for colorectal neoplasia. Secondly, to explore the significance of the microbiome, and then to develop what we call a consent for contact platform. This is our sites in the United Kingdom, and we've recruited about 5,000 patients so far. When we do our fecal immunochemical testing as part of our screening program, we use a small kit like this tube here with the top. And we published this study about a few years ago, which demonstrated that actually the fit kit that you send for screening has sufficient quality of semen matter to be able to analyze the microbiome. This is brilliant because it means that we don't have to ask people to send full stool samples in, but we can do on these samples. So we have, I say, recruit about 5,000 patients. We now have about 1,000 stool samples and about 3,000 blood samples stored. We know that alterations to the gut microbiome and genetic variations are both associated with neoplasia. They're correlated, but could potentially be used for risk stratification. The microbiome is a rapidly evolving area, and we have already one of the largest data sets in the world for gut microbiome. So we just sent our these are some of the microbial risk factors that were really identified in some of the studies internationally. But essentially, we now have a much larger study. You'll see that these have numbers like 300, 200, and we already have around 1,000 samples. So we've just sent our samples off for microbiome analysis, and we should get those back soon, and hopefully be sharing those next year. So as a beginning to round up, I just want to mention fecal chemical testing. The role of FIT in symptomatic patients has expanded hugely in recent years. Endoscopy services are under huge pressure with demand outstripping capacity, and there's a significant desire to remove symptomatic colonoscopy so we can do more asymptomatic screening. We used to FIT a lot more during the pandemic to triage the urgency of referral and determine whether people should be referred. And FIT has grown in use hugely, certainly in the United Kingdom. Because the problem is that colorectal symptoms are fairly ubiquitous, they're fully interdisciplinary, they're low, and we still have too many emergency presentations. So we produce British Society of Gastroenterology guidance, where FIT should be undertaken in primary care, and it should form the basis for colorectal referral. And really importantly, once a FIT has been undertaken, the original symptom no longer has any predictive power. The FIT is so good. So in simple terms, if a couple go to their practitioner together, and so the man has colorectal symptoms of the bowel, bleeding, etc., has a negative FIT, and the woman doesn't have symptoms but hasn't had a FIT, she's more likely to have colorectal cancer than when FIT is that good. This is really growing area. There are some questions around exactly how it will work. So I'm doing some work with a primary care colleague called William Hamilton, looking at whether things like full blood count are additive, etc. And certainly the evidence here that these are different models of complexity, and the red line is FIT alone. That FIT on its own seems to be very, very good. We're also doing work, I mentioned obesity earlier, looking at obesity as a risk factor, and this is a study called Oscar, which we published recently. And we're actually going to develop some interventional studies to try and deal with obesity in the endoscopy setting, more to come in the coming years. When we're doing endoscopy, I think it's very important we remember that patients have the best possible experience of endoscopy. We developed what we call the Newcastle Evidence Plan, which is the first patient-blind, patient-led experience for endoscopy. We validated this in Coventry, upper endoscopy and situs sponge in the UK, and are now validating it internationally. Colleagues in India were interested in working with us on this. We're delighted to work with you. So, our vision for colorectal cancer screening, prevention, and diagnosis is we should be doing an awful lot more research in this area. If you go to an oncologist, most an oncologist generally tends to think is, which clinical trial might this person be in? And I would like us to see a situation where everybody coming for a colonoscopy has the opportunity to be part of the research. And these are some of the studies that we have in our suite of studies. We call it colorectal cancer screening, prevention, endoscopy, and diagnosis. And I hope that this talk to some extent has inspired you around the importance of colorectal cancer, the growing importance in India, and some of the areas of research that we're undertaking. So just to say thank you to the team that I work with. Many people have done a fantastic job working with us. If you're interested in knowing a little bit more about our research, this is our colonoscopy website. So I hope you continue to have a great meeting at Apollo Hospitals. The GI Bleed work goes extremely well, and look forward to continue face-to-face, hopefully in the not too distant future. And thanks.
I think this lecture was very inspirational. I hope we all, screen for colorectal cancer more often. And the rest of the meeting was, of course, excellent.
Thank you very much. I think we will have the next session together.
Thank you. And now for the concluding remarks, we'd like to call on Dr. Palaniswamy and Dr. Motofik, please.
I think you'll all agree that we've had a wonderful half-a-day session on the various aspects of GI bleed, upper small bowel colon, and subsequently, and the case scenarios, the interesting or multiple case scenarios or complex cases were discussed. I think it's very interesting. Because the last one on colorectal cancer screening, that's the most important for our country. I think we should all probably start looking for at least the fecal alkaline blood test in our routine health check. That's very important. I would like to thank all our the international faculty for having time, taking time off and travel by themselves. And also, it's not over today. I think they have many more days of stay in Chennai and training for our younger gastroenterologists to control how to manage the bleeding. So once again, I would like to thank the pharma industry. Without their support, I don't think it's possible to kind of hold such meeting, and the hotel management for all the excellent support. Of course, and the managed event company headed by Santosh, Stage 3, and the team. Thank you very much. And I would like to present the sort of we want to honor all the international faculty. So can I invite all the international faculty to the stage, please?
At the same time, I'd like to thank everybody. It's been a pleasure. I'd like to thank Professor KRP. I think every time we came up with a proposal, it was done. He's been extreme stalwart in this and very supportive. of all our ideas. I'd like to thank my good friend Basu, who's been like my brother in India. We've been working together. I'd like to thank the team of the technical support, the hotel, and everything. I think every day is a school day. We say. I learned today. I think what a fascinating day. Thank you all. It's been. I learned a lot of things, and I'd like to summarize the things I learned. I learned that it's important to work together. You know, the word three musketeers, you know, let's all work together and help our patients, help us ourselves, because we're not going to be here forever, but hopefully our research and everything will continue. And we are keen to collaborate. We want to learn from Indian society and Apollo. That's why we're here. And hopefully this link and relationship will continue. Thank you very much all.
I would like to thank all the participants for having spent the whole half a day here. Hope you all learned every aspect of GI bleeding. Request all of you to join for lunch.